Conventional synthetic disease-modifying anti-rheumatic drugs, CS-DMARD, and biologic DMARDs are two major classes of medications used to treat inflammatory rheumatoid diseases like SPA, RA, psoriatic arthritis, while both of them aim to modify disease process and prevent joint damage. Conventional means as they act a broader and less targeted way than biologics, and they are synthetics because they are chemically manufactured, whereas the biologics are newer agents which are produced from the living cells and designed to target specific molecule or pathway in the immune system involved in inflammation. CS DMARDs and biologic DMARDs differ in mechanism of action, specificity, administration, and side effect profiles. To give a proper knowledge about the use of these drugs, our first presentation will be on CS DMARD and biologic DMARD, contrast and comparison. Before the presentation, I will like to take the privilege to introduce our first speaker, Professor Ved Prakash Chaturvedi. Professor Chaturvedi is one of the few DM qualified rheumatologists in India. He was the senior super specialty in rheumatology and clinical immunology in the Armed Forces, Army Hospital Research and Referral, New Delhi for 37 years. He is the senior consultant and professor of rheumatology in Sir Gangaram Hospital, New Delhi. Vice President of Asia Pacific League of Association of Rheumatology, that is APLA. He achieved his MBBS on 1977 and MD degree on 1984 and DM in 1995. He is the President of Delhi Rheumatology Association, past President of Indian Rheumatology Association, Vice President of Musculoskeletal Ultrasound Society of India. He is the first rheumatologist to start musculoskeletal ultrasound in rheumatology and is the first rheumatologist to establish medical arthroscopy for rheumatologists. Now, I take the privilege to welcome Dr. Ved Prakash Chaturvedi to deliver his speech.
Can you explain?
Left to task kara lag bana data de task
No, this doesn't work?
No.
Okay. Thanks. Good morning, ladies and gentlemen. At the outset, my sincere thanks to Bangladesh Rheumatology Society. Whenever I travel to Bengal, whether it's India, in Calcutta or Dhaka, I always feel I have to learn so much about, it's a different gene. Actually, all my teachers were from Bengal, though I'm from central India, I'm from Delhi. So that is how and I'm seeing from yesterday, whether it's a art or a culture or a science. Thank you so much. All seniors are here. And this lecture is definitely not for the seniors. This lecture is for the... So my brief, I was working earlier in government, in Armed Forces Hospital, we call it research hospital. And now I'm working in a equally good hospital, Gangaram Hospital. There are two Gangaram Hospital for the knowledge. One is in Pakistan and one is in India. And I'm visiting both. Sometime I go there and see. That is how. So I'm working for last 10 years in this Gangaram Hospital. Sorry, I think how to do it? It doesn't work, this?
Yes, sir, it works.
It is not working. It's not working. It's not working. I think it's hang up. Yeah, so my job is very simple, and my lecture is always for the backbenchers, not for the senior people. So we have also learned like this. So if something is very complicated, I generally avoid it. I make things simple, and I'm speaking on a simple topic also about the biologics we are discussing since yesterday, how they compare with the traditional drug, conventional drug, which is sulfasalazine, methotrexate. So that is the, and the disease is this. Look, one belongs to both father and son. Both are from Dubai, and both are my patient. And one is on sulfasalazine for many years. So that was a drug. When we passed out rheumatology, that was a drug we were using, whether it's a axial disease or peripheral disease. So that was, and this boy is taking biologics, but the question is the same. He also asked the same question, which I also have in mind and you also have in mind, whether which is better, whether biologics really works, are they really stop the structural progression, whether they will stop this structural disability, which we call it bamboo spine. So we really don't know. So, I'm sorry, I think this, I can't handle it. Yeah. So that question is always there. These two diseases, look, rheumatoid arthritis is a different disease, especially for the youngsters. Sometimes you do feel problem in diagnosing, but they are two different diseases. One is a synovial disease, another is a disease of ligaments, enthesis. One is a rheumatoid factor positive, another is more stress on the HLA-B27, and one is a lower limb disease only, while the rheumatoid is a hand joint disease, basically. And there are many drugs for rheumatoid arthritis. You just heard the previous speaker, Dr. Gallen, and since yesterday, 1, 2, 3, 4 drugs, they are all conventional synthetic drugs, which we sometimes we call it methotrexate, leflunomide, or so on and so forth, many drugs. But now the JAK inhibitors. But my job is not to speak on JAK inhibitors. My job is to speak on traditional, conventional disease-modifying drugs, how they compare with the biologics when we use in the setting of spondyloarthropathy. So rheumatoid arthritis has so many drugs. But for ankylosing spondylitis or spondyloarthropathy, do we have conventional synthetic drugs or only we have biologics? So let's go ahead. As I said, there are two different diseases. Rheumatoid is a synovial disease. Synovial disease responds to the conventional drugs. That's why peripheral SPA, it responds. But axial SPA doesn't respond because the primary pathology is in the ligament. So basically, if you really ask me, one is a synovial disease. It's like neurology. You have a level of lesion. The level of lesion is synovium in rheumatoid arthritis, while this is the level of lesion is in the, so that there are two different diseases. Obviously, they behave differently. So that is what we have to learn. And the basic pathologies, enthesitis or enthesopathy, and these are the sites which we all miss. Whether you can call a junior person or senior person, it has been ingrained that arthritis, backache. It is not the case. Enthesitis is a different ball game. They will have all these sites which we all miss as a clinician. Somebody has a pelvic pain, somebody has a side pocket pain, somebody has a back pocket pain, somebody has a pain not on the heel. Heel is classical, but shoulder pain, neck pain, and it is more problematic in the women. What is happening? Very senior people like us, we have been missing female ankylosing spondylitis, female SPA, because we always thought all these criterias are backache. Backache, yes. Enthesitis is a different story. And these criterias we know, probably this is the only disease, unlike rheumatoid arthritis, where more stress has been given on imaging. The next lecture is on imaging. So there are two arms. One is an imaging arm, another is a HLA arm. Believe me, when I joined rheumatology in 1990, and if you say that HLA was considered as a research tool. Now tell me, it has become a criteria, that too classification criteria, not diagnostic. So HLA has been given this much importance. So very important, and of course, there are some features of enthesitis, then that is how it is diagnosed. Main level of lesion is here, we all know it. So they will present all symptoms like backache and inflammatory backache, chronic, which we all know about this level of lesion. They will come with a backache, and of course you can have an early disease, late disease, and a very late disease, whatever way you want to call it, pre-radiograph. Of course that will be discussed by Matthew in the next speaker. What is important is you always feel there is a slow progression. All of us feel it's a slow progression because most of the research is based on the X-rays. If you really ask me, this is the syndesmophyte volume. If you measure the volume by a CT, within 1 year you can see, look, this is about 27. Within a year, 5 times bigger. So probably it requires a further research. It's not that slow as we think. So it's probably it progresses, and most of them progresses because a lot of people say they may not progress, and if they progress at this rate. Almost 10% people from early disease to become, so from the non-radiographic, they become radiographic. 10% every 2 years, 12% almost. It's a quite big figures almost. About 5 to 6% people from non-radiographic, they become radiographic. So definitely, and of course you need a special drug for situations like uveitis or IBD related changes, and of course the skin problem like psoriasis, because they all encompasses SPA. So that all they require different drugs in different setting. Sorry. So treatment is very simple. Treatment, whatever guidelines you read A guidelines, B guidelines, daily there will be guidelines. Basically, it's a patient education, physiotherapy, it's an inflammatory disease, it is an auto-inflammatory disease, so you require something for counteract this inflammation, so you require an anti-inflammatory drug, so NSAIDs, and of course, the present topic whether you require traditional conventional DMARDs. So let's hear on that. What is the NSAIDs? NSAID, we all know it. You can use A, B, C, D, and a lot of papers whether you should. Normally people say use it continuously, it is better. You know it, the problems. Now this is one drug which is CS DMARDs. We are using for rheumatoid arthritis. We are using for SPA. As Cochrane review is the most authentic, we know it, it does works in improving morning stiffness and ESR, there's no doubt about it. It also works definitely, it decreases the recurrent uveitis. Over a period of time, for many years, sulfasalazine remains the drug. Sometime came methotrexate, sometime leflunomide, but mostly sulfasalazine. Even today, it is preferred. But people realize that people are still dying. Look, rheumatoid arthritis was given so much importance. But SPA, ankylosing spondylitis, generally administrator will say nobody dies. No, they do die early, and probably the cause are many, not very well researched, maybe amyloid, maybe something else, maybe many. So further research was done, and further research had biopsy from this joint, and this was the when we were just became rheumatologist, and the biopsy showed TNF is high. And who was the person? This was the person which I salute. Believe me, the condition of SPA or ankylosing spondylitis was like osteoarthritis. The moment patient used to walk, people say there is no treatment. A young person coming, and no treatment. That was the answer, except the sulfasalazine or the NSAIDs. But this man changed the whole thing. And actually, anti-TNF drugs were already available. So he said, yes, this is another, besides rheumatoid arthritis, we must use the anti-TNF drug. And then came the anti-TNF drug. They were known as wonder drug that time. There's no wonder in science. Science will keep changing. From today, it is called wonder drug. Tomorrow, it won't be. But that time, and this is the man who's Ravindra Mani. He's an Indian, third generation Indian, who settled in UK. And he's the one who published. And this was the this was the publication. And he came on the main cover. These arthritis rheumatism is like New England Journal of Medicine. They don't publish human photographs. Very rarely they publish. Philip Hanch came on the cover page. This is more than 100 years. It's a basic research journal. When they published this, Mark Feldman and Ravindra Mani on the main cover, they almost got the Nobel Prize. And so that is how this molecules anti-TNF drug came. And anti-TNF drug, when they came, this was a man who was convinced that it can be used for the ankylosing spondylitis. Note the year, a publication in Lancet in 2002. That was the time we were young rheumatologists. And he published about 28 patients. I had already infliximab that time with me. I was using for rheumatoid arthritis. I was having communication with the Ravindra Mani, who always thought it will never work for ankylosing spondylitis. And believe me, why I salute this person, because he was not given drug by the drug company. He was told, don't give him this drug. You know, Britishers, you know, all those issues between the Britishers and German, he was German. He went to US and purchased the drug, and rest is the history. He changed the history of treatment of SPA or ankylosing spondylitis. So he published in 2002, almost similar time, I had about more than 100 patients. Similar time. But I was in government, I couldn't publish it, and about more than 100 patients, and we presented this was our first patient in 2002, almost similar time, because I was having this drug with me, and the moment I read about Jürgen Braun, I was in contact, he said, you use it, and we used it, and this was presented in APLAR. It's not that I didn't present. I did present in the 2005, I think, was the 2005. It was an oral presentation. Jeju was the place, APLAR. We presented, but could not publish it. In any case, what we published, because everybody says these drugs are not good for Asia. You will have a lot of tuberculosis. You have endemicity. You will die, all of them. You don't use it. So what I told Ravindra Mani, that most of the tuberculosis is occurring early. In the ATTRACT trial, most of the cases of tuberculosis, including death, was occurring here. And this is the place occurring early. If you don't do this, this is called loading dose. And we may not have tuberculosis. So what exactly I did, I reduced the loading dose. I said, no loading dose. For last 30 years, I was using these anti-TNF drug. I have never used a loading dose. And I proved to my society also, and I keep telling, and I had a presentation also, APLAR, that if you don't use loading dose, in my series, there was not a single case of tuberculosis. Yes, we do get tuberculosis. That's a different issue. But incidence is very less, and it's not frightening that everybody will have tuberculosis with the anti-TNF. So that is so not a single case of tuberculosis we had. I said, you don't use loading dose and don't use 5 milligram. You use 3 milligram. Because rheumatoid arthritis is a lot of inflammation, while ankylosing spondylitis is less inflammation. What we call it inflammatory load is very less. So you use the low dose. We had many, from 99 onwards, we had about 4,000-5,000 patients. Now came another issue. After we used also for 5,000 patients, 6,000 patients, whether long-term use, what will happen? Continuous long-term anti-TNF therapy, if you use, There is a data of that, yes, the new bone formation can be probably be stopped. That is the data. So probably, yes, they do stop the structural progression. So these are drugs which we all know, this crowd knows about the anti-TNF drugs. Then came, which I was always telling, but nobody listens to us. That is how the Asia is. The criteria, earlier criteria where you use these drugs when you have radiological changes. You have already missed the bus if you have waited so long. So now then came the radiographic and non-radiographic. He said these drugs are not for non-radiographic. You wait till the changes occurs. Probably that was because of the insurance purposes. But as a clinician, you don't follow these guidelines. They are not law. They are just guidelines. All my patients, 5,000 patients, 6,000 patients on infliximab, they were all non-radiographic. Early disease, because I was working in an organization, armed forces, where referral system was so strong, very early disease used to come. Patient was also, treatment was also free, the bed was also free, and so we could collect that early disease data, which now published by this gentleman from Canada, and Harun. Harun published early disease. If you treat, probably if you sufficiently early in the disease course and treatment is sustained for a long period of time, they are most effective. We already knew, but we liked the publication. So publication came. Then came, no, not TNF. It's not only TNF. About 40–50% patient, they don't respond. 60% suppose respond to TNF, 40% don't respond. So further research was done, and the further research was this, the IL-17, which we already know about IL-17. So now there are two molecules. One is a TNF, and another is IL-17. So used anti-IL-17 drug, that is the secukinumab. So that is the, and then people said, why not to use IL-23? IL-23 is sitting here. It is, but surprisingly it doesn't work. So anti-IL-23 doesn't work, anti-TNF works, anti-IL-17 also works. We have also huge experience of IL-17. I'm very sure seniors sitting here, they also have experience of IL-17, secukinumab. It is also effective, very effective. So these two drugs, anti-IL-17, most of TNF and IL-17 work, IL-23 don't work. As I said, whatever guidelines you read, whatever way, I can spend 2 hours on guidelines. The guideline says this, if for a peripheral SPA, sulfasalazine is good. You have a peripheral features, like you have a lower limb oligoarthritis or upper limb oligoarthritis, sulfasalazine works for this. NSAIDs initially, you use NSAIDs initially, and then use sulfasalazine for the peripheral disease. For axial disease, you don't have a DMARDs. You don't have a conventional synthetic DMARD. But this, I'm not talking about JAK inhibitors. This is JAK inhibitors, that's not my topic. But if you really ask me as a clinician, all has been put on the similar platform, whether you use A, B, or C. So don't ask which is better. All has been put in the similar platform. Yes, why anti-TNF is preferred? Anti-TNF is preferred because we have a long experience. Who makes these guidelines? Guidelines are made by people like us. We say we have experience of 30 years. So okay, that is preferred, anti-TNF. But efficacy-wise, all are same. That is how exactly the whole situation is. So that you remember, a special consideration, if somebody has a uveitis, probably you avoid etanercept, but a lot of last Eplar discuss, even that is not very true. So you don't say big no to etanercept. Etanercept can also be used. And if you have IBD, then you avoid anti-IL-17 drug. So my one request to all of you, you are using biologics, you ask about IBD features. Kindly don't use IL-17. Suppose anti-TNF does not work, and you say, okay, I'll write an anti-IL-17 secukinumab, because it can cause perforation. So believe me, you must ask this question repeatedly, whether you has a, I always ask you whether you have a bladder, bowel, skin or eye problem. 4 questions you ask, and that is the best. Of course, we know it about the skin disease where your preference of drug is anti-IL-17, not the other drugs. So anti-IL-17 is a preferred drug. Pregnancy, all anti-TNF are safe. Tuberculosis, anti-IL-17s are preferred. For CCF, heart issues, avoid anti-TNF. Comparison, if you really ask me, between these two drugs about efficacy and limitation, last 4 or 5 slides, basically, CSDMARS is good for the peripheral arthritis, but there is no proven effects for the radiographic progression. So if you compare and contrast with the biologics or anti-TNF, we don't have a very solid proof of this. Yes, they can be used for peripheral arthritis. Limited efficacy, lot of papers keep coming. In fact, from India, from PGI, Shefali wrote about they do work for axial disease, and somebody might stand up and say, no, it works. There are limited efficacy, but if you see the meta-analysis, if you see the Cochrane review, it is used basically for the peripheral arthritis, and there is no proven effect for the radiographic progression. For the biologics, they are effective in both. So that's why they are in. Whether you use for axial disease or a peripheral disease, you can use biologics for both. So that is and it slows down the radiographic progression. So that is very important. The photograph which I showed you, the first question patient is going to ask you, I will become like a bamboo spine? So they do have we do have a proof they stop the structural progression. Yeah. So this is the probably the table which summarizes that for a peripheral disease, it is the conventional synthetic drugs like sulfasalazine, they have effective, but moderate effective. These are more effective. And it is ineffective axial disease, they are ineffective in axial disease, and radiographic progression, and onset of action is slower. Look, society does not want that I start a drug and it will work after 3 months. Society wants a drug. I am appearing for examination, I am a busy professional, so I want that. So fast acting drugs are also preferred. So that is how we compare these two drugs. Safety of conventional synthetic, yes, sometimes you don't say that conventional synthetic is safer. If you see this table, whether conventional synthetic or biological DMARDs, both drugs has issues. These drugs have GI issues. You ask anybody who is taking sulfasalazine, you will come to know he doesn't eat dinner. He always feels full. GI side effects, especially Asians, we are eating a lot of spices. So we are eating a lot of spices. We must use a drug which does not have issues in the GI tract. So that is how the GI, that's why I have highlighted it. Many other, but I have highlighted this. A young person getting married, if you ask a question, does it affect the sperm count? I always thought, no, it's not a big issue. But he showed me his report. He said, sir, you had given me sulfasalazine, my sperm count is 0. So sperm count is, it requires probably more research in this, which biological DMARDs, yes, we do have an increased risk of infection and TB screening and all, but at least they don't have GI side effect. That much I'm convinced about the whole issue. So recommendation whether A, B, C, D, I'm not going to read this recommendation, but what I'm going to tell you, where this is, which I already told you, sulfasalazine for peripheral, biologics for the axial SPA, and whether a Pan-American guidelines, that was Pan-American guidelines also almost same, that sulfasalazine, methotrexate, leflunomide, big no. No for axial disease. So don't even think, because these are most guidelines has been worked on evidence based that they don't, the same is here also. Ultimately same story in all the guidelines. I think these are the last 3 slides. Methotrexate, normally, normally you use methotrexate, you always say that probably the autoantibodies generated by drugs can be reduced, but it's not for SPA. But this is a paper which is say it's good for SP also. So if you use methotrexate, so there is a role. There is a role for CSDMRs that you can use with the biologics. This is one paper which is a recent paper, that is the, and this is the paper which is basically, that is a Chinese paper, but you are using NSAIDs, and you can use as a combination drug. So that is a real-time data on. So you can use basically. Actually speaking, when I read it today, I realized they have used sulfasalazine, fine, but the thalidomide is actually anti-TNF drug. So when I was presenting as a young rheumatologist once, believe me, somebody asked, why you use biologics? Why don't you use thalidomide? I didn't know about thalidomide. Some scientist asked me. So that I remember that thalidomide is an anti-TNF drug. So that is the anti-TNF drug. So this is another by the Grappa. Grappa also says for SPA, whether psoriasis also included in the, so basic drugs, gradually methotrexate role is going down. They are also recommending these drugs, the primary drugs remains. If you ask, all these drugs are basically biologics, and most of the drugs are becoming, so I'll skip this, I'll also skip this. This last two slides, basically role even in psoriasis. Look, I am not a great psoriasis researcher. Grappa is there are many people. So basically they also feel, I don't know, that progressively reduce the recommendation of methotrexate. I'm using methotrexate, right and left. I know it's effective, but it's effective in skin disease. Evidence says it is less effective in the SPA. So naturally, if it is a arthritis, it has a less role. So that is the progressively reducing dose of methotrexate in severe disease. Low dose methotrexate is only marginally effective than placebo. They feel the low dose in psoriasis, psoriatic arthritis, psoriatic SPA, it is no more than a placebo. But we use it and we found it is effective, but that is how what the evidence says. I think this is the last slide probably. There is a place in severe psoriatic arthritis. As I said, that there is a gradual shift in the targeted therapy, like we are using JAK inhibitors. I am very sure this whole crowd is using JAK inhibitors. Gradual shift in psoriasis also from the CSDMARs to the targeted DMARs. So that is how the methotrexate role is becoming less and less, especially for a severe psoriatic arthritis or SPA. To summarize, I call it spinal arthritis. I served in an organization which was full of young males in army. So I have seen plenty. I published in a layman also. I wrote an article, spinal arthritis of young soldiers. I always feel we had given less importance to this, which is a disease of young males, maybe a lone bread earner in the family. So basically, it's a early treatment will give you the best outcomes. Whether you use A drug or B drug, whatever evidence is there, whatever your experience is there, early treatment, you have to take a decision. Don't wait. So that is number one. Anti-TNF drugs are established. That is number one. Anti-IL-17 like secukinumab have also definitely stopped the progression. So both anti-TNF, secukinumab, biologics are probably, as on today, they are superior to conventional synthetic drugs, which was a topic, especially for an axial disease. So there is absolutely evidence for axial disease, no for the conventional synthetic. And JAK inhibitors are the new drugs. So this is the, if you use biologics, what you can achieve? Clinical remission, possible. If you have pain, swelling, stiffness, clinical remission possible. Radiological regression is not possible. If you have a syndesmophyte, they will not regress. But MRI regression is possible. If you have bone marrow edema, this, that regression is possible. And we really don't know whether radiological non-progression is possible or whether we can stop bamboo spine. Yes, they do say that if you use continuously, if you use for an early disease, then probably it is effective. And of course, whether biologics or whether non-biologics, now this is a new kid on the block. Basically, a target depletion of the T cells by TRBV9, I am very sure the students know better than those who have read about this. That is, and I don't believe, this is the last slide. One of my patient, scientist, came. He says, I am going for a bone marrow transplant 30 years back for ankylosing spondylitis. I was giving them infliximab. I said, this is all bunkum. People are earning money for BMT, for everything. That patient for last 20 years without infliximab, and when this thing came, these two slides says probably yes, we do have a case for mesenchymal stem cell or a T cell targeted therapy for these diseases. Only science, this is just one paper, so we really don't know that is going to emerge. One patient of mine himself went, and 20 years back, still, she's a scientist working still in Delhi, so I'm in touch with her. So this was my first patient. I always keep this historical because one day Ravindra Mani told me that you must keep this video. This was the first patient who was on infliximab. In fact, in my country in 2002, he came for bilateral hip replacement and the orthopedic surgeon was good. So he rang me up that you have infliximab, why don't you try? There's a, probably you always tell that you try. So that is how this is the first paper. So once again, thank you so much for giving me time. And this is, I am working in Delhi, anything, and I met a lot of senior people who are in this crowd, and especially I'll read from the juniors because seniors I know, I know Atiq, I know Minhas, Nazrul is the person who was, he's the man who made the scientific program, and I was so amazed since yesterday I was just comparing. I can tell you, whenever I come to Calcutta or Dhaka, I will feel the standards are much higher than the central India. So that is what I feel about the science and culture and everything. And my thanks to junior people also who are sitting here, especially Nahid, Sohab, I met them, and the Arif and Ahmedullah, and of course, Shamim and Shaheen, I can see them on the front for last 2 days. Thank you so much. Thanks.
Sorry for interruption. Just one announcement for the poster presenter. Bangladesh Rheumatology Society has formed a strong jury board headed by Professor M. Mustafa Jaman for unbiased evaluation of your valuable poster. Just I am requesting all the poster presenters, please stand beside your poster. That's why our jury board can take a brief interview for your selection. Thank you very much. Professor Mustafa Jaman sir also requested our another professor, Professor Patwari sir from Sylhet. Patwari sir also is a member of this important jury board. Thank you.
Thank you, Professor Chaturvedi sir, for a very nice presentation and comparison, very elaborative and informative presentation. The term spondyloarthritis used for a family of inflammatory arthritis, maybe axial or peripheral, and may be associated with psoriasis, inflammatory bowel disease, and other conditions. Different forms of SPA share a group of clinical features. The most distinguishing features are inflammation of axial joints, mostly the SI joints, the asymmetric large joints arthritis, mainly the lower limb joints, dactylitis, and enthesitis. Compared to general population, these patients have more frequencies of HLA-B27 association. They can present in various ways, So we have to go through a complete history, elaborative clinical examination, and then some laboratory investigations, and more importantly, imaging, which is the cornerstone of diagnosing axial SPA. Our next presentation will be on imaging in SPA, which will be delivered by Professor Ashish Jacob Matthew. Professor Matthew is a professor of rheumatology at the Christian Medical College, Vellore, India. He completed his undergraduate medical training and residency in medicine and rheumatology training in India. He received a PhD by the University of Copenhagen, Denmark, for his work enthesitis in SPA, including psoriatic arthritis, MRI, and clinical aspects. He did postdoctoral clinical and research fellowship in adult rheumatology, psoriatic arthritis at the University of Toronto, Canada. He has 102 publications, peer-reviewed publications, and with a H index 20. I humbly request Dr. Ashish J. Matthew to deliver his speech.
Thank you very much for that kind introduction. What a pleasure it's been to be in Bangladesh for the first time in my life, and it's been a wonderful time last 2 days, both science and culture what we had last evening. I was wondering when it's going to get over. Probably we could finish that and straight walk into the stage for my talk tomorrow. So I'm going to deal with imaging in spondyloarthritis. The other thing what I wanted to mention was before I came into Dhaka, I had a privilege to visit another university a bit north of Bangladesh. I went to TMSS for a couple of days and had an amazing time looking at the lush green environment around. I stayed in this wonderful hotel close by. I'm pretty sure it's quite common. And what was interesting was the discussion what I had with the whole group of PMR, orthopedics, internal medicine, and also I bumped into this one. I didn't realize this is a UNESCO heritage culture till I attended the first day when we had the inaugural function, and this is apparently one of the three. So that was a plus. Then I met this amazing person who was the chairperson of the TMS's group of institutions, and I was back in Dhaka with a different color altogether. So this has been a wonderful experience. I'd really like to thank the Bangladesh Rheumatology Society for this invitation, and trust me, it's been a lovely time. These are my disclosures. So if you look at the diagnostic process, we learnt about the treatment aspect. Now if you look at the diagnostic process, it's totally a bit different because it's as compared to maybe rheumatoid arthritis where you have rheumatoid factor, you have a couple of imaging, you pretty get close to the diagnosis. But here what happens is you start right on top over here, if I were to, the first one over here, it's basically what we need to understand. It's an integral, stepwise kind of an approach where you integrate clinical history, examination, labs, and imaging findings. And also keeping in mind, the second yellow one is the pre-test probability. I really stress this quite a bit because if we don't get the concept of pre-test probability, we'll start testing each and every one with a HLA-B27, take an X-ray. So what exactly is pre-test probabilities, especially for the young generation, is very important because we are losing sheen. The clinical examination bit seems to be losing sheen these days, and I think that shouldn't be the case. If we are sending an important investigation, we should know what are the risks or what are the chances of that test coming positive for that particular patient. And that's totally different right across, be it in primary setup, it may be a different pretest probability versus somebody who is in a tertiary care setup. Then we move on to a multi-dimensional process, because it's not just one-sided approach when you diagnose spondyloarthritis. And you get smarter by the day. And what I mean is, it can be a learning process on itself. And we always reappraise the diagnosis at each and every follow-up, because it's not something that, now I always say that the spine is not something that we can, touch or, you can examine in a way that it will be positive for inflammatory arthritis. And that's where this whole thing of advanced imaging comes in, which is pretty high sensitivity. And what we need to remember there is, although the sensitivity is really high, it may not be all that specific. I'll come to that in a bit, on what I mean by that. But however, since Professor Chaturvedi did mention about the targeted therapies, what we have in terms of TNF inhibitors, IL-17s, with all these targeted therapy, what we need actually is to have a very sensitive outcome measurement tool. Without that, it becomes a little difficult to kind of, categorize these patients who would be fit for these therapies. So that's where we are in terms of the diagnostic process. So what is the role of imaging in this whole thing? Now, if you go back a step, now what I'm going to cover in the next few minutes is actually touching upon just the axial part, although we do have a big role of imaging in peripheral as well, because in the interest of time, I'll just touch upon the axial part for the reason that that's what really comes to our mind when we talk about axial spondyloarthritis, and not really deviating into the peripheral arthritis or peripheral spondyloarthritis part. So the role of imaging is quite starking because things have moved on over the last couple of decades. We started off with radiography, and I still think radiography in a setup like ours, South Asian setup, radiograph is still a go-to investigations. I wouldn't write it off totally, but we do have some issues, and I'll come to that in a bit. We do have ultrasound, and MRI has come up in the last maybe 30 odd years, and of course you have CT as well. So how do we place each of these against each of them? Now we do have, so I've divided them into the role of these imaging modalities for sacroiliac joints and for the spine. Now if you look at the sacroiliac joints, what MRI picks up, which none of the other things do to that extent, is to pick up the inflammatory lesions of the sacroiliac joint. And when I say inflammatory reason, the reason is today's inflammation is tomorrow's damage. And we don't really want to push the patient from inflammation to damage. And then we have a window of opportunity there to treat the patient. So MRI is probably the only modality among the four which can give a true indication of what really inflammation is. Now, if you look at the structural lesions, which include erosions, can be fat lesions, can be newborn formation or ankylosis, we know that MRI does pretty well for bone erosion as well, and for fat lesions. But where it falls a little bit short is where you have to mention or look into newborn formation, or of course ankylosis, that shouldn't be a problem. And that's where CT scores over MRI, but we do have, thanks to the AI and the good programming, we do have certain new techniques by which we can kind of amalgamate MRI and CT. I'll deal with that also in a bit. So we do have for the spine, again the same thing, inflammation is good in MRI, soft tissue inflammation, but if you look at all the other structural lesions, we have the CT which scores over MRI for most of it by far. And what we need to know is, in fact, if you look at CT, the new DECT, which is dual energy CT, is good at picking up some of the inflammation in certain cases. So that's where this, if you look at the CT, I have a star asterisk up there, which talks about the BME part. So DECT can be helpful in certain patients, but I wouldn't really risk getting so much of radiation for just some inflammation when you have MRI which picks up all these things pretty well. Sorry, it's jumping. Yeah, so let's start with radiography because that's something which we use pretty often, widely available, cheap. We can get an answer straight away. Most of us know a fair bit of radiology, so we can do justice to whatever we see. So the grading, which was proposed way back in 1984, which is a modified New York criteria, has been as hazy as the grading is because it was used till we got better things, and we always used to still go back to radiographs. But if you look at the gradings, it's like it's not a quantifiable thing. It's mostly a comparable thing if it's grade 1 and 2, and then we have the modified New York criteria, which requires at least grade 2 bilaterally to be called spondyloarthritis. And this is where the challenge comes, because if you look at 1 and 2, even 1 and 2 is quite hazy. Even we have some issues reading these. 3, 4, of course, it's quite easy. 0 is easy, 1 is easy, but the 2 and 3, that's where the whole thing, your buck is on 2 and 3, and often there are chances that you can get wrong there. And what we need to remember is this radiographic modified New York criteria was derived, in fact, from patients who had advanced axSpA. And also they had pronounced inter-rater variability. And again, like what I mentioned, it's purely a qualitative threshold for discrimination between the 3. And of course, not to forget the radiation exposure, which is in fact 10 times that of a chest radiograph. Now, the 2 views which we generally use is, AP is by far the most commonly used, but there's something called the Ferguson view, which is kind of an angulated approach because we know that the SI joint is kind of angulated. But a couple of studies have shown that there's no superiority of this Ferguson view over standard AP view. So what is the problem with modified New York criteria? Now, we know that it has a clinical arm and a radiological arm. Radiographs, you need to, like what I mentioned, at least 2, grade 2 bilaterally. But what really happens there is you pick up these changes pretty late into the course of the disease. So in this whole bargain, we lose about 7 to 10 years of disease, and with these molecules what we have today, with the array of fantastic molecules so sensitive, it's not really worth waiting for 7 to 10 years, because once you have damage, you can hardly do much about that. Of course, we do have data coming in for data on reducing the progression of structural damage, but once you have a structural damage, it's after all a damage. You can only reduce the progression, but you can't really go back in time and fix it. So that's the problem with modified New York criteria. And then we have these problems with sensitivity. Now these are data from Desir cohort and SPACE cohort. Desir had patients from 18 to 50 who had inflammatory back pain of at least 2.5 or less than 3 years of disease. And SPACE had early onset SPA, in which again symptom onset should have been less than 45 years of age, and an undiagnosed back pain, regardless of what, they didn't really mention about inflammation, undiagnosed back pain of less than 2 years. What I wanted to bring to your attention is the percentage of patients who actually fulfilled modified New York criteria. Now, if you look at the inflammatory back pain in Desir cohort, it's pretty high sensitivity for diagnosis of axSpA, but only 13.5% of patients were radiographically positive, and in SPACE, only 11.6 patients were positive. So that's the problem with radiography. And if you look at the inter-rater reliability between trained readers, it's pretty poor. This is again data from the Desir cohort, in which central reader 1 and central reader 2 had just about 0.54 kappa for lesions of axSpA. And same thing with a local reader and central reader 2 or 3, it was pretty poor. So what I want to bring together is, now again, the other positive side of radiographs was, this is actually a training program we did in Copenhagen as part of the EuroSpA registry, in which we divided patients into inexperienced and experienced readers. Both of them had to go through 3 exercises. Exercise 1 was a set of lectures. Exercise 2 was actually scoring some images. Then you go back and do the lectures again and score a 3rd time. So that was exercise 1, 2, 3 to your left. What we found out was, if you look at all 19 readers, and here we have inexperienced and experienced divided over here, but if you look at all the 19 readers, it was, in fact, this kind of teaching and then kind of getting them ready to score was really helpful. And most of them had pretty good kappa levels as the training progressed. So if you compare exercise 1 to 3, there was a huge difference between, the improvement was quite striking. So there is room for learning and to get things moving even for radiography. Now, when you come to diagnosis, let's talk about this gentleman whom I saw about a few months ago. He's a 34-year-old man with, he's an IT professional with 6 months history of low back pain. Somebody took an X-ray which looked pretty good, except for maybe on the left side there's a bit of a hazy thing. You can argue on that, but overall this looks pretty okay. I'll come to that in a bit. We'll just shift gears and move to the spine. Now, spine has been somewhere close to where a radiograph would be helpful, but there again, actually you end up picking structural damage. You're not really just doing justice with picking up the inflammatory lesions. So here I'd like to bring in the spine lesions. These are, this is squaring. So this is what is squaring of the anterior border of the vertebra. You have syndesmophytes and you have corner lesions. So this was the initial thing for spine, spine radiograph. This is again 2 radiographs of the spine, which actually shows facet joint ankylosis on both the sides. So once you have a full damage, there's hardly much you can do about. Here again, if you look at the thin arrow, it just shows bridging osteophyte. You also have a fair amount of osteophyte over here, and this is actually a syndesmophyte fusing. This patient also has a fair bit of osteophyte, and that's another tricky thing, because if you look at the data from psoriatic axial disease, data from the German cohort has shown that a fair 60% of patients who have axial disease do have degenerative changes as well. So it's a bit of a maze when you get into that area. And if you look at these broken arrows, dotted ones, these denote squaring of the vertebrae. And we do have scoring systems for this. One of them, which is widely used, is the modified Stokes ankylosing spondylitis spine score, which is MSAS. We do have RAS, but this is by far the most used one, which generally scores the cervical and the lumbar vertebrae. So thoracic is not really included. What really is included is C2, the upper border or the lower upper border of C2, all the way to the lower border of C7, and then you start with L1 and L5. So a score of 72 is what it leads you to. 0 is normal. 1 actually includes erosions at the corners. It can have sclerosis and squaring. So if any of these 3 are there, you score 1. Obvious syndesmophytes are 2, and then you have bridges, which is 3. This is 3. 2 over there and 1 here. So back to our patient, so much so for the spine. Back to our patient, I did mention about this X-ray and told you that there was some bit of a hazy thing on the left side, on the right side in fact, but look at his MRI. What was a normal, almost normal looking radiograph, we see a fair bit of inflammation out here, a capsulitis, bone marrow edema, and a small erosion out here which cannot be picked up in the X-ray. So here I have my case that you have to get an MRI if you have to detect early. But if you are happy with structural damage, I think X-ray should be fine. Now, what are the advantages? Now, if you look at radiographs, now radiographs tell you what has happened in the past. It doesn't tell you what's going to happen in the future. If you look at MRI, it tells you what happened, what is happening at the current point in time and what may happen in the future. So that's a major thing when you have treatment decisions to be made for these patients. Diagnostic evaluation, monitoring, sensitive outcome measurement tool, all these things are pretty good for MRI as compared to radiograph. And of course, MRI just does help in selecting the patient early and thus reducing the structural damage. And that's what we should be focusing on, because once you have a structural damage, there's hardly much we can do about it. Now, this is a study done by the Berlin group where they compared radiographs and MRI, because one of the major flaws which MRI was supposed to go through was, in fact, its comparison with radiographs for structural damage. And, but this study, in which the reference standard was CT, and they compared radiographs and MRI for structural lesions, and we see that MRI fared pretty well as opposed to CT. It was close to 0.85 as compared to the sensitivity was 85% as close to CT as opposed to 48 for radiographs. So we know that MRI is good for structural lesions as well as compared to X-ray. So coming to the, what we need to understand is a few anatomical considerations when we talk about MRI. Now this is the sacroiliac joint we're talking about. It has an anterior part, a posterior part. It has so the anterior part of the SI joint is actually the cartilaginous part, and the posterior is the ligamentous part. So that's what we do. And if you look at the posterior part over here, this red part is the ligamentous part. But what is our area of interest is just this bit, which is the anterior part, because anterior part is the synovial joint, and posteriorly, if you go into the ligamentous part, it is more, that's mostly used for differential diagnosis than for diagnosing disease itself. So that's the part what we are really interested in. That's the ileal bit. That's the cartilaginous part, and this is the synovial joint, what we actually score. Now, we need to remember, or unless we ask for what sequences we want, the radiologist may take their own views and start doing it, and then we have to interpret in a way that we would like to. So that's where we have this recently published guidelines on how to order an MRI. Essentially, we always remember that there has to be two orientation. One has to be a semi-coronal, and the reason for semi-coronal is because the SI joint is not a straight joint. So this is the coronal plane if I were to take a slice perpendicular. But since the SI joint is slanting, you need a semi-coronal, which is actually angulated, and it is actually, if you draw it, it's the dorsal part of S2 is parallel to this plane. So that is where the reference thing is. And you have a semi-axial, which is again the perpendicular to the dorsal part of S2. So that is the landmark. Now, what are the sequences? We know that MRI has a T1 and a T2. It's pretty simple. What we need to know is what are to be ordered. We need to have a T1 spin echo or T1 sequence, which is for structural damage. We need to have a T2 fat suppressed signal, which is bone marrow edema sensitive, which could have pretty much the new techniques as well. And the third one should be, so I did mention that MRI may not be the best for erosions. Now, if you look at the third sequence, which is actually should be ordered, is actually a thin slice, which could be a 3D gradient echo, which is strongly recommended in the current guidelines, and for the same reason, for the reason of picking up erosions early in the disease. Semi-axial can be just a T2 weighted suppressed fat suppressed signal, which can be a BME, and which is essentially to double check on active inflammation. The reason I'll come to that in a bit. So that's the orientation what I was talking to you about. So we have the semi-coronal and semi-axial. And now what to look for? We generally look for bone marrow edema in patients with inflammatory lesions and structural lesions. We have fat metaplasia, bone erosions, fat metaplasia in erosion cavity, which is also called backfill, and of course ankylosis. So jumping slides. So this is bone marrow edema. If you look at, so whenever you read an MRI, you need to have a T1 and T2 sequences together, and we actually look at both because both are comparable and both are complementary to each other. So here you have the water sensitive image, which is the stir, which is quite bright, and here the corresponding T1 is rather a low signal because it's fat. This is a water sensitive, this is fat sensitive. So, and what we compare is this part, which is the interforaminal bone marrow signal, is the normal reference for assignment of normal signal for bone marrow edema, and subchondral region is the most affected ones generally. So unless you have an edema in the subchondral region, it may not be actual bone marrow edema. Now, 2010 was the first time when Uli Weber and his group described that even normal people do have false positive. In fact, they do have BME, but if you look at the anatomical position of these BME, these can distinguish between a normal as well as abnormal. Here we have mostly patients do have a normal patient who are runners or pregnancy, postpartum, antepartum women. Most of them have their bone marrow edema in the anterior part of sacrum, if you look at this one, and the posterior part of ileum. So anterior sacrum and inferior ileum, these are the two areas where you can get false positive bone marrow edema in patients who may not have axial spondyloarthritis. And what really determines is the extent. So if you have at least 3 SIJ quadrants with a depth of 1 centimeter, the chances are more that it will be related to axSpA. Fat metaplasia is another structural lesion, one of the first ones, which is generally noted in T1 sequence. But what we need to understand here is there are 3 things what we need to remember. It has to be around the cartilage. It has to have a well-distinct border. And also it has to be homogeneously bright or homogeneous signal across. Because fat, we know that there can be conversion of red to yellow fat as the person ages. And we know that up to 70% of patients do have some amount of fat metaplasia as they age, beyond 50 years of age. So I think that's very important. Bone erosions is one area, what I said, MRI has not been all that great up till now, but we do have sequences like Weib and Dixon, which essentially helps us to understand the bone cartilage interface where you have these erosions. So moving on, fat metaplasia in erosion cavity backfill. This is something which is added recently as in like about 5 years ago into the definition. And this actually depicts what axial spondyloarthritis is. Now, if you look at the axial spondyloarthritis, we have a normal joint here. It gets eroded, and then you have fat which gets filled up in that erosion, which is what I mentioned as fat metaplasia in an erosion cavity, and that gradually works its way into ankylosis. So that's the progression of axial spondyloarthritis we know about. Bone sclerosis is quite common in women, where you have both the sequences showing a low signal. Now, MRI-based synthetic CT is something what I was talking about initially, which is something which has just come up. This was for the SI joint, this is a study done by the Belgium group. Lennart Jans was the author there. They did MRI. So what is MRI synthetic CT is actually a software where you take MRI and that can be converted to a resolution which is close to a CT. So you can get away with the problem with radiation, and you get fantastic images which is which is, in fact, this is the CT and that's the synthetic image. So you can see how good and comparable these two are. In fact, they compared these two and they found that it is pretty good. So this is where MRI is today, because we do have ways by which we can get around the problem with structural damage. Now, anatomical distribution, what we know is BME is very common, but like what I mentioned, if you have more the numbers and wider the BME, it's mostly for axpa, fat lesions, mainly in axpa, but mostly in the sacral quadrants. Erosions are rarely seen in other diseases, but there again, if you have an iliac and mostly bilateral, it's for axpa. Morphological lesions, this is again 2 studies done in Denmark, and these were the depth of fat metaplasia just shows how important it is, because if you have a wider depth, it's mostly seen in axpa. Fat depth of more than 5 millimeter is mostly in axpa. BME of 5 millimeter and more with erosion is mostly axpa, but once you have a ligamentous erosion, it's exclusively for axpa, although we don't really look at that part. But if you do see an erosion, it's mostly there. This is actually a work done in my institute where we looked at unilateral sacroiliitis, because this is very common in this part of the world because we have a lot of infections. And we figured out that large erosions had odds of close to about 18 for an infective thing as infective etiology. So the one on the left is all infective images, both, so you can see the collections over here. This is an abscess over here, and these are unilateral SI joint involvement in axpa. So a large erosion, widening of joint space with effusion, and BME on both iliac and sacral side are more for infective. So what do we do when you have a strong clinical suspicion of axpa, but the MRI is negative? So essentially the bottom line is you repeat after 6 to 12 months. You have to wait and repeat. Now, there are a few definitions which have just come up for the spine as well, vertebral body. So earlier, if you look at the Berlin score, it was mostly including the central part of the vertebral body. But now we know that the lesions can be posterior. It can affect your facet joints and all the posterior structures. So this particular one gave updated definitions for all these structures, including the posterior and spines, both for inflammatory lesions and structural lesions. These are a few of the, I'll skip these things in the interest of time. And these are the lesions what we have for MRI of the spine, which now if you look at this part, this is a schematic diagram of what's actually happening here, which we can't really visualize as well. And that's because you have syndesmophytes which are not really visible in MRI. So that's one part which MRI, again, like what I mentioned, fell a little short as compared to CT. But that's where, again, we have the synthetic CT. This is a recent study from Denmark in which they had 18 patients who underwent MRI-based CT, low-dose CT, and X-ray. And look at the amazing quality of these images using CT synthetic, and they compared it with CT. So as low-dose CT as being the reference standard, we see that structural CT or synthetic CT and radiographs. So here we see both have very good specificity. So essentially synthetic CT is as good as radiographs as compared to low-dose CT. And if you look at the sensitivity, it's 0.67 versus 0.31 for radiographs and 0.61 versus 0.48 for the entire spine, C2 and facet joints. So essentially, we are inching closer to the time when MRI is going to be as safe, as good as CT for picking up structural damage, but safer than CT in terms of radiation. Now, what we again need to understand is we are working for a patient who is right in front of us, and we have to plan the treatment. So what is really important is the same language what is communicated to the radiologist, because if you give jargon, you get a report jargon back. And garbage in, garbage out. So that shouldn't be the thing. And this was actually a project of the ASAS where it was decided to come up with a summary of referral recommendations. So you should always give demographics and relevant clinical information, including age, sex, and HLA-B27, history of back pain, physical activities, previous imaging, suspected or previous clinical diagnosis, and imaging contraindications. And the radiologist is also supposed to get back to you with a certain number of objective parameters. So generally what happens is back pain, do MRI, right? That's generally what a radiologist gets. So the answer should be, we don't know. Like, unless you give clinical reasons, it's very difficult for the radiologist to figure out what exactly it is. So this is actually just come up in ARD. You can check this out, and it's a wonderful thing to keep in mind. So key takeaways is imaging is key in early diagnosis and monitoring structural lesions. Radiograph mostly talk about damage. MRI, you can have inflammation and damage. Now that is more important because we need to treat these patients, and we know that inflammation leads to damage. MRI is quite sensitive, but beware of false positives. And rheumatologists should actually be well trained in interpreting MRI, SI joint, and spine. And always remember, it has to be a contextual interpretation of inflammatory and structural lesions together, and because otherwise you can overcall things. And always provide adequate clinical information to the radiologist to get a meaningful report back. Thank you again for this wonderful opportunity, and I look forward to having any questions, or if not, I'll be happy to answer your questions outside. Thank you very much.
Thank you, Professor Matthew, for a very nice presentation. For time constraint, we are not taking any questions for this. Sir. Sorry, sir, for as we have limited time. So I am going to request our speakers to give some comments for the presentations. First, Professor Abul Kalam Azad, sir. Please, sir, say a few words.
Assalamu alaikum. Thanks, Nadia Tottenham, my dear beloved student and good moderator. Thanks, Bangladesh Society of Rheumatology, giving me the opportunity to say something in front of you, and giving the opportunity. I am highly privileged to hear in front of you as the chairperson of this session. And in this session, there are two nice topics. First one is presented by Professor Ved Prakash Chaturvedi. He is excellent. He is a conventional and biologics DMRD. He nicely presented that when to start the diagnosis, the early diagnosis of the treatment, when need to treatment, if there is a delay in the treatment, there is a lot of complication. And also Professor Ashish Matthews, she also mentioned that there is a delay in the diagnosis, onset of the symptom to delay, and the onset of the diagnosis is near about 7 to 10 years. By this time, there is a lot of complication. So we need to treat early the treatment. And there is a Professor Deprasad mentioned nicely, there is a very little no role or in the treatment of the conventional DMRDs in the axial arthritis, and there is very limited role in the peripheral arthritis. And also there is a very limited role in the psoriatic arthritis, and also when associated with ulcerative colitis or Crohn's disease. So there is a role of the biologics. Okay, in our country there is a highly privileged, and there is a very high incidence of tuberculosis and other. So prior to institution, he mentioned that we should treat the patient if there is tuberculosis, and there is also extraordinary vigilance for the survey of the other infection also. So he also mentioned there is the role of anti-TNF, and where we should use even in the pregnancy, and where we can use the IL-17 inhibitor. That's also just touches the Janus kinase inhibitors. And next presenter regarding the diagnosis. Okay, and Professor Matthew nicely mentioned there is a very little or limited role in the early diagnosis of the radiological conventional radiography. So MRI is a very good option, but it's highly expensive in our country, and its sensitivity is near about 85%, and specificity is very high, and so MRI is a very good option. There are other radiological survey that is SPECT, we can do SPECT, we can do the PET CT scan, but it's a very rare in our country, and we can provide such type of investigation. And there is he also mentioned there is a bone marrow edema. There is a lot of causes of bone marrow edema. So there may be overdiagnosis with the MRI. So we rheumatologists and radiologists there should be proper knowledge about this thing, the bone marrow edema and other things, so they can easily differentiate these those type of the other cause of the bone marrow edema. And CRP is a very important role, and proper examination, there is no role of exclusion of the proper examination. So examination, history and CRP and other irrelevant, it will help to establish the diagnosis. Thanks for again.
Now I request Professor Mohammad Nozrul sir to say a few words.
Thanks moderator, and thanks the speakers from the abroad, Professor Bhed and Matthew, and for the trouble taking to visits and enlightened us with some knowledge. For my beloved doctors, junior doctors, my take-home message to you is that this is only the tips of the iceberg, a little of the tip of the iceberg we try to expose in front of you. From on your part, if you are interested to be a physician of spondyloarthropathy, you need to dig as much as you can. Starting from infection to that of the false diagnosis, and the outcome assessment also should be your field of interest. With all of that, thank you very much for giving me the opportunity.
Thank you, sir. Now it's time for giving away the mementos to the speakers. I will request our chairpersons and Professor Matthew to give memento to Professor Raj Tv, sir. Now, Professor Ashish Matthew, sir, please will receive his memento from our chairpersons, and Professor Raj Tv, sir, please come. Thank you.
Thank you, Nadia. Excellent moderation. I like to invite Dr. Suleiman Rajan to conduct the next session. Dr. Suleiman Rajan.
Distinguished guests and from home and abroad and dear audience, me, Dr. Suleiman Rajan, welcome each one of you to this session. This session is on patient empowerment and drug adherence. I extend a warm welcome to the chairperson of this session, Professor Brigadier General Mamun Mustafi sir and Professor Major General Muhammad Shamim Haidar sir, and whose presence make a remarkable value in this session. We have two distinguished speakers. Professor Syed Atikul Haq will talk on patient empowerment in clinical practice, and Professor Dr. Roshanara Madam will talk on anti-rheumatic drugs and pregnancy. I humbly request the chairpersons and two speakers to come into dais and have their seats. Thank you. And now, the few words for my first presenter, my mentor, Professor Syed Atikul Haq. Syed Atikul Haq, sir, Chief Consultant of Green Life Center of Rheumatic Care and Research, a retired professor from Department of Rheumatology, Bangabandhu Sheikh Mujibur Medical University, and immediate past president of Asia Pacific League of Association for Rheumatology. He established first rheumatology clinic in Bangladesh in 1991. He participated in forming for Bangladesh Rheumatology Society in 1997 and is now its president. The Department of Rheumatology was established at BSMMO in 2012 and Dr. Hawk became its first chairman. He received the International Fellowship in the American College of Rheumatology in 2005. He was awarded a gold medal by the Bangladesh International Academy of Science. Now he serves APLAR as the convener of the APLAR Social Committee and Patient Outreach SIG. Now I request my mentor Professor Syed Atikul Haq sir to deliver her talk.
Respected chairpersons and dear colleagues, thank you. I thank the organizers for inviting me to deliver a talk before this learned gathering. I am just putting a self restriction. My topic is patient empowerment in rheumatology practice. Yes. Oh, okay. What is patient empowerment? It is a process to gain greater control over decisions and actions influencing health and to obtain the ability to control one's life. And what are the aims? First one is enhance autonomy, enable the patients to identify the needs, to think critically, to make informed decisions, solve problems, master their life situations, and manage pain and disability. What are the ingredients of patient empowerment? One is adequate individual patient education, involving the patients to understand their roles in the management of their disease, encouraging them to become co-actors in shared decision making, to modulate patients' belief in their capacity to manage their everyday life, make informed decisions regarding their health and life. What are the requisites for patient education, patient empowerment? Number one is adequate knowledge, enabling the engagement and awareness of their own role in the care process, acquisition of specific skills, and existence of a facilitating environment. What are the outcomes of patient empowerment? Better patient outcomes, such as better adaptation to their long-term conditions, better quality of life and well-being, more independence from the healthcare providers and carers. This is actually, sorry. What are the empowering interventions? The patient-centered training interventions, shared decision-making, motivational interviews, counseling, health coaching, signposting to support services. And what may be the relevant support services? Training programs for clinicians and for patients, supporting educational materials, expert patient programs, chronic disease self-management programs, personalized care planning, patient education programs. What are the moderators? Okay, I'm just skipping this slide. What are the indicators of patient? How we shall understand that this patient has been empowered? Patient capacities and beliefs, self-efficacy, sense of meaning of life, and health literacy. And in actions and behavior, we may judge that, they can participate in shared decision making, taking an active role and making informed consent, informed decisions about their health and health care, self-manage their conditions by choosing meaningful and realistic goals and taking steps to achieve those goals, participate in collective activities such as participating in patient supports and advocacy groups, and search for information about their health condition, for example, on the internet. In our country, we doctors have a tendency to criticize whenever a patient tries to acquire knowledge on his disease. Rather, it should be encouraged. We should not criticize that. And there are several patient empowerment scales. The level of empowerment that the patient has achieved can be measured. One is empowerment scale for mental health, diabetes empowerment scale, patient empowerment scale for cancer, and Swedish rheumatic disease empowerment scale for arthritis. This is one study in which the researchers used that Swedish questionnaire to measure, patient empowerment in a group of 844 patients. And just you can see here, this, the dark circle, it indicates low empowerment. Actually, this is not working nicely. Okay. The uppermost, the topmost one is the dark circle. It represents lower levels of empowerment, and the inverted triangle, dark inverted triangle, indicates higher level of patient empowerment. And you can see throughout the 15 years, those with poorer empowerment suffered from greater pain, and those with a stronger or higher level of empowerment suffered from lesser pain. And similarly, here you can see this is about the disability. Those with lower empowerment suffer more from disability, and those with higher level of empowerment suffer less from disability. What are the determinants in this study? What are the predictors of low empowerment? Low knowledge, older age, female gender, living alone, lower physical ability, and higher total joint count, pain, fatigue, and lower quality of life at the baseline. And the inferences were, it may be important to identify patients with low levels of impairment. They may need extra support in managing symptoms, and they may require rehabilitation interventions that are targeted to promote patient empowerment. Now I am going to some independent contributors to patient empowerment. These are several, patient-clinician communication, self-efficacy, shared decision-making, trust in physicians, self-management, patient education, patient-centered care, and patient satisfaction. So now about patient-clinician communication. How should we communicate with the patients, and how the patients will communicate with us? There must be active participation in interviews and better level of preparation for consultation with the healthcare providers, level of knowledge of the disease and its implications, ability to control and monitor treatment progress, treatment adherence, and disease-related lifestyle adjustments. And now, the factors correlating to an appropriate patient-clinician communication are patient participation, building a mutual trust, efficient shared decision-making, and treatment satisfaction. এগুলো তো সব উল্টাপাল্টা হয়ে গেছে। এটা আসলে মামুন সাহেব তো আমার মনে এডিটেড ভার্সনটা আনেননি, কিন্তু আমি একটা এডিট করে পাঠিয়েছিলাম, তার জায়গায় একটা পুরানো ভার্সন এখানে দেওয়া হয়ে গেছে। আই এম ভেরি সরি। আসলে self-efficacy. What is self-efficacy? It is the ability to set goals and accomplish them, boosting empowerment and contributing to healthy self-management. One of the several interrelated factors that contribute to patient empowerment, and there are also ways for measuring self-efficacy. One is rheumatoid arthritis self-efficacy scale, and the other is arthritis self-efficacy scale. These are in relation to rheumatic disorders, but also there are self-efficacy scale for other chronic conditions like diabetes, depression, and higher level of self-efficacy has been reported to be associated with lesser pain, inflammation, disease activity, medication, higher medication adherence, and a higher level of function and quality of life. Shared decision making. Shared decision making is a new therapeutic decision making process. You know, it means taking distances from the old paternalistic model. For example, what is in our country, possibly also in India, the situation is same. The doctors or the specialists consider themselves as the boss or God sitting on the altar and consider patients as our slaves. And we must get, rid of such a mentality, and we should switch to sharing them with each discussion on each issues. Both the physicians and patients are essential components. The physician contributes with experience and expertise in clinical guidelines and treatment targets. The patient expresses his or her personal preferences and goals, as well as expectation from the treatment. What are the steps of shared decision making? We have to first describe the natural course of the disease, to describe the therapeutic options to patients, and encourage them to participate in conversation actively, to explain the potential risk and benefits of each option, to consider and evaluate patients' doubts and preferences, to reach a shared decision on the best option, and to critically evaluate the decision and express any concern at the beginning of that specific medication. How to make shared decision making effective? By providing more information to the patient and showing greater sensitivity and respect for patient's concern, offering more reassurance and support, using simple, easily understandable language and avoiding technical language, and efficient use of non-verbal communication by our look, by eye, everything. And, okay, I am skipping this slide also. And, what are the outcomes of shared decision making? It increases adherence. And also, there are certain risk factors for therapy discontinuation, lack of information on the risk and benefit of therapeutic options, and inadequate communication between physicians and the patients. Trust in physicians. Trust is the key component of the doctor-patient relationship. Patients who trust their physicians are more likely to communicate about their medical problems. What is the physician's attribute for trust? The informativeness. The physician must provide information to the patient, sensitivity to patient's concern, patient-centered behavior, and use of a comprehensible language. And there are also tools for measuring trust in physician. One is Hall's Trust in Physician Scale and Trust in Physicians Scale by Anderson and Dedrick. What are the outcomes of trust in physician? Adherence to treatment, satisfaction with care, greater use of clinical services, improved quality of life, and better health outcomes. Self-management. Day-to-day tasks an individual must undertake to control or reduce the impact of diseases on physical health state. It involves patient taking increased responsibility for their health in terms of decisions they make and activities they engage in. This can greatly improve health outcomes and the individual's quality of life. Patient education is integral to the success of self-managing a chronic disease. What are the responsibilities of the patient? The patient must understand his responsibilities for, successfully managing themselves. They have to use the medications properly, change their health behavior to improve symptoms or slow down the disease process. They must adjust to their condition, social and economic and emotional. And they should report their symptoms accurately to their healthcare providers. This is an article on 2021 Euler recommendation for the implementation of self-management strategies. How Euler defines self-management: the ability of the individual to deal with symptoms, treatment, lifestyle changes, psychosocial and cultural consequences of the condition, and it is inspired by two key factors. The patient should achieve independence, and the idea that self-management should be supported by also others like family, patient organizations, healthcare professionals. Why self-management is important? Patients need to develop a higher self-awareness of their condition, and the healthcare system, if the system has to tackle the whole range of the, disabilities or other complaints, other discomfort, everything, then the cost of healthcare will become too high. And what are the consequences at individual level? Greater confidence in dealing with management, suspicion of immunosuppressive therapy in case of infection, ability to identify symptoms or signs needing immediate medical attention, and emotional management. What is the composition of self-management? Predisposing factors, motivation, self-efficacy, self-confidence shown by patients playing an active role in their decision, reinforcing factor by family, patient organization, healthcare professions, and enabling factors are problem-solving skills and access to healthcare information. Patient education. What is patient education? Patient education is a planned interactive learning process designed to support and enable people to manage their life with inflammatory arthropathies and optimize their health and well-being. What are the goals of patient education? The primary goal of patient education is no longer only knowledge transfer and disease control, but also to enable patients to manage their illness, adjust to their condition, and maintain the quality of life. And these are the ways in which patient education may be arranged. Face-to-face meeting, then online, video, telephone support, and written paper communications. These are the Euler recommendation for patient education. Patient education is an integral part of standard care. Patient education must be offered throughout the course of treatment. It must be tailored and need-based, and the various modes of delivery should be utilized, and the outcomes should be evaluated with objective measures. It should be delivered by trained and competent deliverers, and the providers also should undertake training to achieve that competence. This is a study on patient education. There are actually 3 studies on patient education. One is patient education of RA patients in Bangladesh. Another study was on the report on the impact of patient education. And the third was a survey on the state of patient education in Asia Pacific. About the knowledge of patients, this was a study undertaken in the Department of Rheumatology, Bangabandhu Sheikh Mujib Medical University. 168 patients with rheumatoid arthritis were evaluated about their knowledge on rheumatoid arthritis, and this is Bangla Patient Knowledge Questionnaire, BPQQ. The score was 9.84 in our patients. The mean score was 9.84, and the range was between 1 and 20 out of a possible maximum of 30. So we can conclude that the patient knowledge score was low in our rheumatoid arthritis patient who participated in this study. And the lowest was in medications and joint protection and conservation. The knowledge level was higher in 6 patients who attended in the in patient education session in the past. And this patient knowledge questionnaire score showed a positive correlation with education level and a negative correlation with HAC. A report on the impact of patient education, there 59 patients were enrolled in a Singaporean study, and 22 out of those 59 defaulted over 4-year follow-up period, and out of those defaulters, 6 had attended the patient education session, 16 did not. 37 adhered to the treatment, and out of them 28 attended the education session, and 9 did not. At multivariate analysis, patient education at onset was the singular predictor of adherence. This was a survey on patient education in the Asia Pacific. These are the researchers who participated in this survey. The objective was, compiling background of socioeconomic data, categorizing professionals involved in patient education, methods of patient education, and content coverage. I am skipping the details. Okay, I am sorry, actually my time is over, so just I shall go to the end. These are the things that I could not cover: patient-centered care. The conclusion should be the successful empowerment involves patient education, shared decision-making, and a supportive environment. Effective shared decision-making requires clear communication, patient involvement, mutual respect between patients and healthcare providers. By focusing on empowerment, we can create more patient-centered healthcare. Patient empowerment is crucial for improving self-efficacy, adherence to treatment, and overall quality of life. This is a famous quote from Carl Jung. He was the father of analytical psychology. And he said, "Who looks outside dreams, who looks inside awakes." So let us all awake ourselves. Thank you very much.
Thank you, sir. Thank you for your brilliant presentation. Actually, there is a paradigm shift in the patient care model from paternalistic approach to patient-centered approach, in which patient education is must, and it will help in relationship building and overall better outcome of the patient. Now it is the time for second part of the session, and this session will be talk on antirheumatic drugs and pregnancy. And this will be talked by Professor Dr. Roshanara Madam. Professor Roshanara Madam is currently a professor in the Department of Medicine at Green Life Medical College in Dhaka, Bangladesh. She passed her MBBS degree from Chittagong Medical College and obtained her fellowship in internal medicine and MD in rheumatology. She had several fellowship training in home and abroad. Currently, she serves as a treasurer of Bangladesh Rheumatology Society and has contributed 29 publications in different journals. I request Professor Dr. Roshanara Madam to say a speech.
Thank you, Dr. Rajan, for kind introduction. I know everybody is getting hungry, so let's start. Honorable chairpersons and co-presenter. So my topic is antirheumatic drugs in pregnancy. So understanding the interplay of chronic disease management and reproductive health is crucial. We all know since the thalidomide tragedy of 1960 to 1962, drug safety in pregnancy is a global concern. One study shown recently that 92% of women have at least one drug prescribed by their physicians during pregnancy, and 3.9% are given 10 or more. With the changing paradigm of rheumatic disease management, it is essential to understand the art of using antirheumatic drugs in pregnancy. So my topic outline will be, first, some issues related to pregnancy in rheumatic diseases, then association of pregnancy and drugs, Then the main topic, use of anti-rheumatic drugs in pregnancy. Then some practice points and direction to future research and some concluding remarks. Let's first see some issues related to pregnancy in rheumatic diseases. We all know rheumatic diseases are common in women, and many of the diseases affects mainly the women of reproductive age group like SLA. But fortunately, the fertility of the women is most of the time protected and is not unaltered by the disease. And we all know, dear audience, by this time, the prognosis of the rheumatic diseases improves significantly with the newer drugs, and also the prognosis of pregnancy outcome is also improved. With currently available anti-rheumatic drugs, most of the time we can achieve remission or at least low disease activities. But the problem, the drugs we are using to achieve that doesn't have the adequate safety data. For managing pregnancy in rheumatic diseases, we need to know some points like effect of disease on pregnancy, then pregnancy on disease, lastly drugs on fetus or mother. Today my talk is mostly on the last point. Let's see some association of pregnancy and drugs. Drug treatment presents some special concern in pregnancy. We all know when a woman gets pregnant, the first impulse is to stop all the drugs. So this is very important that the patient with chronic conditions, the drug has to be continued for successful outcome of the pregnancy. But pregnancy affects the pharmacokinetics and pharmacodynamics of medications. Certain medications can cross placenta and may cause fetal harm. Physicians should know pregnancy implications of all prescribed medications. This is very important. But the problem is the evidence. Conducting RCTs in pregnancy and lactation considered as unethical. So the data mostly come from the animal studies. Among medication approved by FDA from 2000 to 2010, over 70% had no published human data and 98% had insufficient data to characterize the risk. We all know the pregnancy risk was previously expressed as pregnancy category A, B, C, D and X. But since 2015, FDA changed these later categories to PLLR, that is pregnancy and lactation labeling or final rule. We all know this pregnancy category, and now the new labeling here, the categories will be like pregnancy, lactation with narration of the all available data. So why the change is? The change because the category, letter category A, B, C, D, it actually quantifies the amount of data, not the quality. So they changes the labeling, and we need to see the labeling about this. Instead of FDA letter categories, now anti-rheumatic drugs are categorized as their evidence of safety or fetal harm. So now there are 4 categories. The first one is minimal fetal or maternal risk. In this category, the drugs are hydroxychloroquine, sulfasalazine, low-dose aspirin, and azathioprine. Selective use allowed during pregnancy. Among this category, NSAIDs, glucocorticoids, TNF inhibitors, IVIG, cyclosporin, tacrolimus is here. Next category is moderate to high risk of fetal harm. This category includes cyclophosphamide, methotrexate, mycophenolate mofetil, leflunomide. There are many drugs that actually grouped in limited information available. So here the biologics and the small molecule. There are some drugs with unknown risk. The unknown risk doesn't imply the safety of the pregnancy and lactation. So now I am going to discuss a little bit about these drugs, and mostly the patient with these rheumatic condition will require some of these medication. So let's see the status of those drugs along with the updates. So hydroxychloroquine can be continued during pregnancy, we all know that, and benefits of hydroxychloroquine during pregnancy outweigh the potential risk. But recently there was a small alarm. We know the studies and the gathering of data is continuing. So this 2021 data of hydroxychloroquine early in pregnancy and risk of birth defect with a lot of patients, like 2,045 hydroxychloroquine exposed and 21,679 maxed unexposed data, that shows that there was a small risk of major congenital malformation, relative risk 1.2. So we were really worried. But after that, in 2022, another data published that actually showed that though the sample size was not that much large, but there was no congenital anomalies among the infants exposed to hydroxychloroquine. We all know there are many studies have suggested that continuation of hydroxychloroquine may improve pregnancy outcome in women with SLE. Another important drug we have to use is sulfasalazine. It is considered to be safe during pregnancy. It is used to be the pregnancy category B. Concomitant folate supplementation is advised. Most of the data actually came from the patient with inflammatory bowel disease. So you can see this is a very old study, but sulfasalazine pregnancy safety has been proved like 40 years now. Another important drug that we can use during pregnancy is azathioprine and 6-mercaptopurine. Azathioprine can be used during pregnancy because placenta metabolizes azathioprine to thiourea acid, which is inactive. So it doesn't increase the risk of teratogenicity. But there is higher rate of low birth weight, prematurity, and jaundice has been reported. So now come to the next category, that is the selective use allowed during pregnancy. That means if we think the patient required this drug and patient's benefit outweigh the risk, then we can use definitely these drugs. NSAIDs we need to use for many rheumatic conditions during pregnancy. So its safety we need to know. Use in early pregnancy may be associated with increased risk of miscarriage and may impede the ovulation and conception. And we all know third trimester use may cause premature closure of the ductus arteriosus. So we can use in the second trimester up to 20 weeks. And NSAIDs used during pregnancy, it is preferable to use the non-selective NSAIDs than COX-2 inhibitor. Another very important drug is glucocorticoid. We need to use this drug to treat active symptoms and flares during pregnancy. Use of glucocorticoid, we all know it's not really teratogenic, but it has its own problem. Like non-pregnant ladies or non-pregnant individuals, the glucocorticoid adverse events is related to the dose and duration. We should use non-fluorinated glucocorticoid, that is prednisolone, methylprednisolone, because it cannot cross the placenta. Initially, there was some report showed that the early trimester exposure of glucocorticoid may cause fetal cleft palate, but that's not actually established with later studies. But there is its own risk of gestational hypertension, diabetes, association with preterm delivery, premature rupture membrane, preeclampsia, preterm birth, etc. So another drug, we all know, we all heard a lot of things regarding these drugs this morning, that is tumor necrosis factors, factor inhibitors. It may be used in women who require these medications during pregnancy. Though some experts shows that discontinuation in the late second or early third trimester should be done, but newer information coming up showing that these drugs can be extended to a later gestational age if benefits outweigh potential risk. We should not use the live vaccines of the baby up to the 6 months. Cetrulizumab is the drug which is not available in our country, can be used throughout the pregnancy. But here is some good news, because just recently published this year a data that showed that accidental live vaccine before 6 months with patient who received TNF inhibitor throughout the pregnancy actually didn't show the significant adverse events. So this is a little bit of reassuring for us. Another very important drug we need to use is calcineurin inhibitors, that is cyclosporin and tacrolimus. This use is compatible with pregnancy, and most of the time this data came from the transplant registries, so the patient's comorbidity was there, but there are no congenital anomalies showed, but the prematurity and IUGR, these are common among these pregnant, these babies. So we need to regular monitoring of blood pressure and renal function is recommended if we use these drugs during pregnancy. So here is a very recent publications in 2024 where in 632 SLE patients cohort, 39 patients reported 42 pregnancies, 3 patients used cyclosporin and 2 used tacrolimus, whose pregnancy was completely healthy. The pregnancy of 2 patients who used azathioprine and 1 last patient who used no immunosuppressive, the treatment ended in abortion. So here is the point, we need to consider that the patient where we use azathioprine, we may switch to calcineurin inhibitors. More data is required to confirm these findings. So now the moderate to high risk of fetal harm, that means we should not use this drug unless there is no other alternative. These are the drugs, we already know the names, and this has teratogenic potential. Even cyclophosphamide is gonadotoxic. So before using these drugs, we need to discuss the issues with the patient, and though the medical termination is not recommended with using these drugs. Now some few words regarding the non-TNF biologics and targeted synthetic agents. These drugs are under the very limited information available about the pregnancy safety data. So the guidelines mostly discourage non-TNF inhibitor biologic use during pregnancy due to that inadequate data. And there is a systematic review in 2021 where they include 109 studies with 1291 pregnancies reported to exposure of non-TNF biologics and targeted synthetic DMARD. There are 66% successful pregnancy, and there was not that major concern regarding congenital anomalies, but we need more data. For the non-TNF biologics, one important drug which is available in our country is rituximab. So rituximab can be used through conception if maternal life is in risk. While the manufacturer recommends the continuing this medication for 1 year prior to conception, in life-threatening conditions, when maternal life at risk, we can use this drug when potential risk is less than the benefit. So here is a case series of rituximab use, where they shows that there is some patient who come up with a successful pregnancy, but we need more data for recommendations. Another newer drug is secukinumab. The guidelines recommend discontinuation at conception, citing the limited evidence. But there is a database by Novartis Global Safety Database, where they actually reported 18 women who continued treatment during pregnancy, and 3 continued at least until the 3rd trimester. Among them, 2 infants had congenital malformation. So we need to be very careful about secukinumab. So another drug is belimumab and tocilizumab. Insufficient evidence to determine the pregnancy compatibility, so the guidelines recommend discontinuation at conception. Now the most actually used drug nowadays in our country is tofacitinib, baricitinib and upadacitinib. The citing insufficient safety information, ACR didn't provide a formal recommendation regarding maternal treatment, but British Society of Rheumatology recommends discontinuation of JAK inhibitor at least 2 weeks prior to conception, and EULAR recommend discontinuation 2 months prior to conception. So these drugs are still not pregnancy compatible. Data are coming up. We need to be, every time the newer informations are coming up, we have to go through this for our individual patient management. Here are some practice points. All rheumatic patients with childbearing potential should get counseling from the beginning regarding importance of planned pregnancy. And if feasible, start pregnancy compatible medication at first. Patient with unsafe medications, discontinuation or substitution with pregnancy compatible medication should plan months prior to conception, because after discontinuation there may be flare which need to be controlled. Try to achieve remission or at least low disease activity prior conception. Provide all safety data to the patient and her family so that they can be reassured. Explain monitoring and follow-up plan from the very beginning. After conception, use drugs with highest long-term safety record at first. Use lowest effective dose to get desirable effects. We need to practice multidisciplinary approach. Consulting with the gynecologist is very important. Encourage patients requiring medications, especially newer one, to enter into the pregnancy registries so that we can have the data for future use. Ladies and gentlemen, I am almost at the end of my presentation. Just recently, a review article published, that is the safety of medication used to treat autoimmune rheumatic disease during pregnancy and lactation, where they compile all the newer informations along with the ACR, EULAR and BSR recommendations. So for better management of our patient, I suggest we can go through this thoroughly. So for the future research, the safety of newer drugs are very important. We need to plan this, how we can get more information. And we also need for more data on long-term outcome of our children, those children whose mother was on anti-rheumatic medication during pregnancy. Because outcomes of children born to mother with systemic lupus erythematosus exposed to hydroxychloroquine or azathioprine showed that with hydroxychloroquine there was no safety concern, but the azathioprine use was associated with increased reporting of childhood infection, which warrants further study. So in conclusion, I would like to say, using anti-rheumatic drugs during pregnancy poses special challenges. Achieving and maintaining disease remission with pregnancy-compatible medications optimizes pregnancy outcomes. Pre-pregnancy counseling and planned pregnancy will ensure better drug adherence during pregnancy. Many medications are considered safe for use in pregnancy. We should use those drugs. Further research is needed, especially for newer agents. So with this, viewers, I would like to thank all the audience for patient hearing. Thank you very much.
Thank you, madam, for your brilliant and time-demanding talk. Due to time constraints, we are not taking any question and answer session. Now it is time for take some valuable comments from our honorable guest. At first, I am requesting Professor Brigadier General Mamun Mustafi sir to say something about the session.
Bismillahirrahmanirrahim. Very good afternoon to all the audience. I'm really amazed, very happy to see such a very good audience in the rheumatology sessions. Excellent. The rheumatology team is working so nicely and the most updated knowledge has been disseminated so nicely. So that's why our next generation is coming up so in a large amount. Today's presentations in these sessions was also extraordinary. A very common problem and very common issues, the anti-rheumatic drugs during the pregnancy. Professor Roshnara has deliberated her presentations in an extremely concise way and very nice way. The things is that there are a few drugs which you can use. That is the hydroxychloroquine, that is the sulfasalazine. There is something we should extremely avoid, the cyclophosphamide, rituximab, mycophenolate, then leflunomide and methotrexate. But in extreme crisis, when the life is very important, nothing is important, we have to go all out to save the life. Even we can use the cyclophosphamide, you can use the rituximab also. The knowledge that we have taken from this presentation is definitely long lasting, and thank you, Professor Roshnara, for giving a very nice presentations. Today, this morning, while coming to this hospital, venue, I had a patient. While coming out of the patients from the ICU, the patient's husband said, I have got an objection. The duty doctor has an interaction with the duty doctor, and the husband said that I will not allow the doctor to treat my patients. So I am not going in details to that, but that is the patient's empowerment. WHO say that patient should be in the environment he can take her or his own decision. Patient should be skilled, that is, and knowledgeous that what is happening, what is going to happen, and what is the effect and after effect of the treatment that is being given. And with all these, the patient should be empowered to take his or her decisions to control the management, the ongoing process. My teacher, Professor Atikul Haq, Syed Atikul Haq, has presented this as extraordinary, rare, undiscussed chapter so nicely. Hats off you, sir. Thank you very much. Excellent presentations. So, ladies and gentlemen, my wholehearted congratulations to the presentators and the rheumatology team for a beautiful session. Thank you very much. Allah Hafiz.
Thank you, sir. Now I am requesting Major General Muhammad Shamim Haidar sir to say something.
Professor Major General Shamim Haidar is an excellent human being, an extraordinary academician. Fortunately, I am his teacher, and he is, like my dear audience, I am just going to get an announcement that he has taken as the Director General of the Drug Administration of Bangladesh this morning. Allah.
Thank you, sir. Good afternoon, learned audience. Don't want to miss one more information. During my intern period, I was direct student of our legend rheumatologist, Professor Syed Atikul Haq sir at Osmani Medical College in 91. And after joining army, I was a resident under Professor Brigadier General Mamun Mustafi sir in 95. So it's a great pride for me to sit here. This only is a great pride. Rest is not to be explained. And it's also a matter of great courage to utter something in front of my teachers. With their humble permission, just I want to mention that about the topic patient empowerment in rheumatology. It has got a great impact, and informed patients can have better outcomes always. And educating patients about their conditions, treatment options, self-management strategies, we foster a collaborative environment. And engaging patients in their care encourages them to communicate openly with their healthcare teams, allowing for personalized treatments, adjustments, and better management options. About the second topic, very much pertinent in our day-to-day life for all doctors, not only for rheumatologists, especially one or more drugs which are prescribed right and left in the community, like chocolates. I mean Janus kinase inhibitors. Everybody is prescribing, and we have seen that it has yet to be settled whether they are safe in pregnancy or not. And those who are already proved to be safe, we remain to be within that. And beyond all, pregnancy should be pre-planned, and the patients should have proper information, education, and preparation for pregnancy, those who have got inflammatory joint diseases. Thank you all. Thank you, learned audience and my teachers. Assalamu alaikum.
Thank you. Thank you, sir, for your brilliant comment. Now it is the time for distribution of mementos. I humbly request the chairpersons to hand over the crest to our mentors, Professor Syed Atikul Haq sir. Now I am requesting Professor Dr. Shonara Madam to take her crest from the Honorable Chairperson.
Assalamu alaikum, respected participants. We are ending this session. Now, the session of gout, this is the last session of 16th International Conference of Bangladesh Rheumatology Society. I welcome Dr. Abdul Razzaq to conduct the session.
Thank you, Ahmed Bhai, for nice introduction. This is the last and most important session about gout. This session is shared by Professor Birendranath Bhattacharjee and Professor Mujibur Rahman, all other sir, Honorable Vice Principal, BSS MIMU. And this session has two speakers, First speaker talk about pearls and pitfall about gout, Dr. Raushanara, Dr. Sabrina Yasmin, and update management of gout is speak by Professor MD Abu Shaheen. I invited both all speakers and chairpersons in the dais. Please, sir and speakers. I am telling about first speaker, Dr. Sabrina Yasmin. He is graduated MBBS in 1999 from Sir Salimullah Medical College, and he obtained FCBS, BCPS fellowship in 2011, and also honored and achieved MD degree in 2016 from BSMMU. She is currently acting as associate professor in Bardem General Hospital, and she has awarded Copcott Award, honorable, I think he received, and he completed it very successfully. She has Keith and can inspire, educate, encourage, and motivate the patients. Now I am inviting Dr. Sabrina Yasmin to talk about her deliver his speech.
Thank you, moderator. Thanks, the chair, distinguished guests and learned audience. ক্ষুধার রাজ্যে পৃথিবী গদ্যময়, পূর্ণিমার চাঁদ যেন ঝলসানো রুটি। আজ সেখানে সায়েন্টিফিক সেমিনার তো কিছুই না। Ladies and gentlemen, I am seeing that all of you are hungry. So I will not take more time. I will be very quick and keep my presentation in brief. এটা কোনটা? এদিকে যাবে? হ্যাঁ, ঠিক আছে। You can see the beautiful ladies. She is Kate Winslet. She is the Rose. She is the actress of Titanic. In this film, she has owned a very beautiful crystal. And this crystal is a 56 carat blue color. It is named at the heart of the ocean. And it has cost about more than $5 million US. But what you have seen, at the end of the Titanic, Rose tossed it into the ocean. Because how worthless the heart of the ocean, this costly crystal necklace becomes when people stand with the question of life and death. Ladies and gentlemen, today I am not talking about the value of this crystal. I am going to talk about the pearls and pitfalls of the crystal-associated disease that is gout. Before going to my presentation, I will show you some scenarios. A 65-year-old obese woman who has mechanical pain in her both knees, and her acute phase reactants are all normal, and she has negative rheumatoid factor and ICPA. But her serum uric acid level was 7.5 milligram per deciliter. She has various deformity in her knees, so she is a clean-cut case of knee osteoarthritis with slightly elevated range of serum uric acid level. A 50-year-old woman has presented with arthritis involving small joints of hands with deformities for 8 years. Her uric acid level also 8.9 milligram per deciliter. So she is a case of deforming RA with slightly elevated level of serum uric acid. A 25-year-old man presented with moderate pain in his right ankle joint for 24 hours. He had a mild fall and twisting of the ankle prior to his onset of the pain. On examination, the lateral side of the ankle was swollen and tender. His Taylor test was also positive, but his uric acid level found 8.2 milligram per deciliter. So, he is diagnosed as a case of lateral ankle sprain with slightly elevated level of uric acid. The last scenario is a 55-year-old woman had presented with somatoform disorder like tension type headache, irritable bowel syndrome, and non-restorative sleep. Her goals was normal. Acute phase reactant and rheumatoid factors, vitamin D level, thyroid functions also are normal, but serum uric acid was 7.8. So she is a case of fibromyalgia with hyperuricemia. Should we treat all these 4 cases with urate-lowering drugs? I say no, because all of them has slightly elevated uric acid level, but they have specific diagnosis. But what is the facts? Unfortunately, all 4 patients were treated with urate-lowering drugs, febuxostat. Dear audience, remember, all the hyperuricemia are not gout. Gout has its typical presentation. A 50-year-old man presented to our outpatient department. He is obese, hypertensive, and has type 2 diabetes mellitus. He came to us with the complaints of sudden severe pain in his left great toe for 2 days. His pain was so excruciating that it wake up him at night and difficult to walk. He had no prior history of similar episodes, but he reported a recent increase in consumption of red meat and alcohol at a social gathering. His hypertension was managed with thiazide type of diuretics. His father is a case of gouty arthritis patient, and he noticed sometimes he has a bad headache. For this, he used to take aspirin. On physical examination, his BMI was 31, and he has mild distressing pain to his left great toe, which was red, hot, swollen, and extremely tender, and there is limited range of motion. Laboratory investigation shows joint fluid aspiration reveals monosodium urate crystals, and his uric acid level is 9.5 milligram per deciliter. His renal function is normal. So what is the case? It is a clean-cut case of acute gouty arthritis affecting the first metatarsophalangeal joint. So this patient is managed by acute flare treatment like NSAIDs and colchicine. And we educate the patient regarding the chronic nature of the disease, and long-term treatment even in case of silent disease can be given. But most important thing is he has to educate regarding the lifestyle modification, regular exercise, avoiding the high purine diets, and increased intake of low-fat dairy products, vegetables, and encourage adequate hydration. His antihypertensive drug was adjusted in spite of thiazide diuretics, and his aspirin was stopped. After 2 weeks, his pain subsided, and he has complete improvement without any further flare. So long-term management is needed for him or not? I think my second speaker will answer this question. What are the keepers in this case? Keepers, when gout present as a classical presentation, early diagnosis and intervention is very easy. But dietary education should be emphasized to the patients, and medication or any other risk factors should be told to the patient. What are the pitfalls in this case? Dietary inordinations. We told our patients about the dietary advice, but if the patient fails to maintain this, there is chance of recurrence of the disease. And medication that are used for gouty arthritis has so many side effects. Like in case of colchicine, there is GI upsets and patient used to stop the medication, and for this they have again flare of the disease. In case of long-term urate lowering drugs, especially allopurinol, it may have hypersensitive reaction which may occur slight skin reaction to toxic epidermal necrolysis. And most important thing is lifestyle factor. Obesity and alcohol are ongoing risk factors for gouty attack. So if the patient fails to notice his body weight and also alcohol use, he cannot prevent his further attack. Few common questions that arises regarding gout. Number one, why gout predilection to the first metatarsophalangeal joint? Second thing is, how spontaneous resolution of acute attack occur, and why precipitation of acute attack by trauma, surgery, or so on. Learned audience, you know that the first metatarsal joint is the most peripheral part and most coolest part of the body. And uric acid has the tendency to precipitate at the coolest part. So the solubility of monosodium urine falls rapidly with decreasing temperature. At that time, phagocytosis of these crystals by neutrophils leads to the acute attack. Why spontaneous resolution of this acute attack? Because when synovial inflammation occurs, at that time increased production of transforming growth factor beta 1, interleukin 1 receptor antagonist, interleukin 10, soluble tumor necrotic factor receptor 1 and 2, all these intercellular cytokine inducible protein and suppressor of cytokine signaling protein are associated with spontaneous resolution of the condition. Is gout always limited to a single joint? I will say no. Because gout may present as a polyarticular disease. When to suspect gout in case of a patient with polyarthritis? When a patient presented with polyarthritis does not fit into the clinical pattern of typical rheumatoid arthritis or spondyloarthropathy or other types of connective tissue disease, and the patient has at least acute monoarticular attack before polyarthritis, the patient has nodular swelling, that is tophi, or joint fluid aspiration shows monosodium urate crystals, and when we can do the X-ray of that joint, it shows punch out lesion, lytic lesion with a sclerotic overhanging margin or double contour sign during ultrasonogram of that joint. Distinguished guest and learned audience, you know that the high serum uric acid level has little value when the presentation is atypical. Presentation of chronic polyarthritis like this, a 55-year-old man who is obese, hypertensive and has type 2 diabetes. He has a history of recurrent bouts of multiple joint pain over past 5 years, and it is typically triggered by dietary discretion, and presented to our outpatient department with painful swollen right grade 2 over 24 hours. His pain was so excruciating, particularly at night, that made him difficult to walk. And when we done the joint fluid aspiration and study under polarized microscopy, it shows the monosodium urate crystal. His recent blood test was also shows high serum uric acid level. X-ray of his joint shows this type of lytic lesion and overhanging sclerotic margin. Ultrasonography of this joint shows double contour sign. So, this is a case of chronic gouty arthritis with tophus. In this case, what are the pearls? Pearls, due to its polyarticular presentation, when we have found the monosodium urate crystal and we have found the punch out lesion and double contour sign, it is a case of gouty arthritis. And we treated him by lifestyle modification, early intervention with NSAIDs, and we advised him to take the long-term medication with allopurinol, which is golden standard nowadays. For education of the patient, we have to remember that he has to educate about the recognizing early signs of the flare so that he can take early medications to prevent the further attack and his disabilities, and initiating appropriate treatment, adherence to treatment, and monitoring of serum uric acid is mandatory. What common mistakes and challenges in these cases? First mistake is we are treating maximally the acute flare. We are ignoring the risk factors and underlying causes that can make his suffering prolonged. Inadequate management of acute attack sometimes occur when the patient has so many comorbidities like CKD. Chronic kidney disease patient with high dose of NSAID may be devastating. Patient may have poor adherence to urate lowering drugs. I have told you the urate lowering drugs has so many side effects. So sometimes patients may quit their drugs. And dietary misconception. Many of our physicians told to the patient that incorrectly told them to avoid all kind of protein-rich food that make him malnourished. And last thing is failure to monitor. Medication adjustment may not be made in time because if we don't monitor our patient regularly. So these are the risk factors of increasing or recurrent attack of gouts. And this type of drugs like thiazide loop diuretics, anti-tubercular drugs, beta blocker, low dose aspirin, and in our rheumatological practice, tacrolimus, cyclosporin, rituximab, all these drugs can increase serum uric acid level. What was the outcome of our patient? We managed our patient by NSAIDs in his acute flare. After that, we advised him allopurinol, which was gold standard. His dietary advice or lifestyle modification was done, and he was regularly followed up. So, over next 6 months, his uric acid dropped to 5.8 milligram per DL, and he experiences no further flare-up. But how long we have to continue these drugs? As there is a question of economic status of the patients. I think it will be answered by my co-speaker. Another important thing is This is the last important thing, that is asymptomatic hyperuricemia. Mr. X, he is 48-year-old male office worker. He is obese and has hypertension, which is well controlled with drugs. His father has gout, but he has no history of smoking, joint pain or any kidney stone or kidney diseases. After a routine checkup, he showed that his uric acid level was 8.7 milligram per deciliter, but with normal renal function. So, he is a case of obesity with hypertension and asymptomatic hyperuricemia. But somehow, he was advised to take febuxostat. What is the pulse of this case? Pulse is asymptomatic hyperuricemia is common in middle-aged men, and it may remain asymptomatic lifelong, but a subset of patients may develop gout and nephrolithiasis. But when there is association of metabolic problem, there is chance of gouty arthritis. So what we have to do? We have to watch and waiting for is there any symptoms or not. We should not treat the patient at the first time with asymptomatic hyperuricemia. Asymptomatic hyperuricemia may increase the cardiovascular risk, but still it is debated. What is the pitfalls or challenges of asymptomatic hyperuricemia case? It is almost all times is overtreated. Maximum patient was advised to take urate lowering drugs, that is the febuxostat. Overprescribing may lead to major side effects of these patients. And the misdiagnosis. Asymptomatic hyperuricemia should not be equated with gout. So watchful waiting rather than aggressive treatment is done in this case. Patient should be adequately counseled. We should not ignoring the underlying conditions. Maybe secondary to renal insufficiency, this hyperuricemia can occur, and failure to investigate other contributory factors that I have shown, drugs, dehydration, etc., should be mandatory. There is a myth, high serum uric acid level is very much dangerous, and it should be treated as soon as possible. But hyperuricemia is very common biochemical aberration. Only 20 to 25% of adult men and similar proportion of postmenopausal women may develop disease condition, and 16% develops a clinical consequence after a big lag of 20 years. So, think that hyperuricemia itself is not a disease. My message to our clinician is careful evaluation must be needed in case of asymptomatic hyperuricemia. He or she doesn't necessitate pharmacological treatment unless there is complications. Focus should be given their lifestyle modification, hydration, comorbidities, and watchful monitoring should be done, and renal dose should be adjusted in case of CKD patients. Avoiding unnecessary medication and recognizing when intervention is warranted are key considerations for clinician to improve the quality of life. I'm at the end of my session. This is my last slide. And we are deeply mourned by the passing of Professor Devashish Danda, who was my soul brother. He was a highly reputed member of the global rheumatology community, And this is the last picture with me in December 2023 in Appler. His contribution to the field were immense, and his passion for improving patient care was unparalleled. Though he is no longer with us, but his memory, his great works, his sincerity will always inspire and guide us in the field of rheumatology. Thank you all.
Thank you, Dr. Sabrina Yasmin, for her nice talk. She highlighted about gout is not an inflammatory disease actually, though it is represented as inflammation. It is actually disease of metabolic disorder of uric acid, and that is triggered by hypertension, obesity, and dyslipidemia mainly. And gout there is treatment modalities, different kinds of treatment are exhibited in our society. This time I want to invite my direct teachers, Professor MD Abu Shahin sir. Abu Shahin sir was graduated from MBBS in 1997 from Rajshahi Medical College, and he achieved BCBS honor, FCBS follow in 2008, and he also achieved his MD degree in rheumatology first time in Bangladesh in 2012. Now I invite my sir to talk about gout management, and now he is coming with his insight and thoughts about gout.
Respected chairpersons, ladies and gentlemen, Assalamu alaikum. Please be seated. Please remain seated. I shall try to finish my lecture within time, less than allocated time, inshallah. My topic is an update management of gout. Basically, gout management, we should follow two broad headings. One is non-pharm management and another one is pharmacological management. So, whom to approach non-pharmacological treatment? Patient with gout, that means a diagnosed case of gout, who do not have current indication to start urate lowering drugs. I like to show it later on. Patient diagnosed with gout but cannot tolerate urate lowering drugs. Finally, there may be an adjunct to urate lowering drugs. Another group, patient at risk of developing gout. Patient who have asymptomatic hyperuricemia and who has had significant risk factor or family history of gout. Now, what are the non-pharm strategies? Treatment of comorbid conditions. Majority of our gout patient and especially elderly patient has had coexisting obesity, hypertension, diabetes, so we should address this. And another, to address the medication, aspirin, diuretics that may precipitate gout. Exercise and dietary modification is very important part of non-pharm management of gout. What are the dietary modification? There are many myths and facts regarding dietary modification. Majority doctor I know, stop this drug, not take any type of fruit, vegetable, leafy vegetable, red meat. But this is not true. We should limit some diet, but not avoid. Here I like to show high purine diet, red meat, shellfish, alcoholic beverage, high fructose containing syrup, sugar, sweetened beverage we are taking in this hotel also. Considering DASH dietary plan, Mediterranean diet, and adequate protein from plant-based source and low-fat dairy product. Patient education, this is also important. We have to explain and we have to educate the patient regarding signs and symptoms of gout flare. That patient can already know what is gout and what are the basic presentation of gout, factors that increase the risk of gout flare, NTPC benefited, potential harms, and common misconceptions that already Dr. Sabrina, my previous speaker, mentioned. Gout is a rich man's disease. It is true? No. What dietary modification we have to understand? And what are the pharmacological management? Two main components. One is urate lowering drugs and another drugs, anti-inflammatory drugs for prevention of gout flare. So, everybody you know what are the indications of urate lowering drugs. We know 2 or more flare annually, patient having tophi, polyarticular gout, tophaceous deposit, and sometimes those who have high risk factors for gout. What are the high risk factors? We must consider high baseline serum urate level, early onset of symptom, genetically determined disease, intolerance to medication used in management during acute gout flare. And if we see monosodium urate deposit in our ultrasound findings, in that case, these patients will be considered as high-risk group. Now come to the targeted therapy. Throughout the world, nowadays, we are following treat-to-target approach. This is the ideal approach. So what should we consider before treat-to-target approach? We have to know target urate level, monitoring to maintain the target, efficacy of targeted approach, and is very low uric acid level is safe or not. Many of our doctors are thinking, oh no, very low uric acid level, please stop, this is harmful. This is really misconception. We have to know, we have to do the data and work that is ongoing throughout the world. What should be the target urate level? The most widely recommended goal is less than 6 milligram. And goal should be less than 5 milligram who has tophi. You know the maintenance of this subsaturating level delays the nucleation of new crystals, and most expert, I already mentioned group, support this treat-to-target approach. How to monitor? One approach, there are many consensus. One approach, urate level should be measured at least 2 weeks on the given dose and should be repeated 3 monthly up to goal achieves. And if goal is achieved or confirmed, then measure every 6 months for the next year and then annually. Not so frequently, monthly, and some our patient is doing himself or herself their uric acid level every visit before coming his doctor. This is not true. This should not be. So, I like to discuss what is the efficacy of targeted approach. This is a study report published in Lancet 2018, where more than 500 patients of a GP in UK are enrolled, compared with nurse-led care. What they found? After 2 years, patient receiving nurse-led care, urate level was less than 6%. In nurse-led group, 6 milligram, 95 versus 30%, risk ratio was 3.8. So, what it was proven? Patient in nurse-led group has had a greater reduction of tophi and improved quality of life. and safety of low urate level. Already I mentioned what is the level, lower level that is safe. It is clearly patient receiving no lower limit of serum urate level. Population-based lower level is called 3 milligram per DL. But what we are thinking, what are bubbling in our mind sometimes, the adverse neurological or cardiovascular consequence is very low urate level claimed, but not yet established at all. And best example is pegloticase was no adverse consequence in profound reduction of urate level, often to unmeasurable level over many months to many years. So it is proof that even zero urate level is not harmful for we and our patient. Now, initiation of and duration of pharmacotherapy. Timing of initiation of therapy. This is also a controversy issue. In our practice, many of our doctors are giving urate-lowering drug simultaneously with the flare. But great majority of doctors throughout the world, they are prescribing, they are using urate-lowering drug at least two weeks after subsiding acute flare. So what should we do? What is the rationale? Usually at least 2 weeks of gout flare, but selected patient, difficult to manage, better to initiate during a flare. The rationale of delaying start. No evidence that initiation during a gout flare promotes better outcome. Look at this slide. Serum urate level in a normal range in 25 to 40% of the patient during gout flare. So immediate addition ignores the accurate baseline. So we don't know what was the level of this particular patient before the attack. Urate lowering therapy in the course of anti-inflammatory flare treatment has possibility to cloud the interpretation of adverse effect. Which drug is the culprit for this adverse effect? We don't know. The start of therapy until after flare resolution can precipitate gout. This is important issue, I think you all know. Now come to the prophylaxis during initiation and urate lowering therapy. Most commonly we are giving colchicine prophylaxis unless and otherwise it is contraindicated. It reduces the frequency of gout flare early in the course of the treatment. Typical colchicine regimen is, 0.5 to 6.6 milligram in our country. 0.6 milligram tablet is available. That's why we are using this tablet. Older patient, it should be reduced because colchicine side effect is more in elderly patient. In case of renal impairment, we should use it cautiously. The dose should be reduced 1 tablet per day, maximum stage 3 CKD, especially creatinine clearance 30 to 60 ml per minute. Half tablet for stage 4 CKD and stage 5 CKD better to avoid. Sometimes when colchicine is contraindicated or patient cannot tolerate colchicine, we can use NSAIDs, low-dose NSAIDs, especially naproxen and other NSAID we can use as a prophylaxis for gout patient. How long we should give this prophylaxis? It depends on several factors. Majority suggests that concurrent treatment of flare usually 6 months. Patient without tophi can often be safely discontinued 3 to 6 months after normal urate level. American College of Rheumatology guideline in 2022, they incorporate also these 3 to 6 months. Though with tophi it is uncertain, but at least 6 months we should give. This is our practice. Choosing of urate lowering drug. Who is drug? We should give from the very first day of our diagnosis. Urate lowering medication, you know, these are the urate lowering medication. Everybody, you know, xanthine oxidase inhibitor, uricosuric drug. Sometimes we are using or we have to use combination therapy, and uricase is another drug. The factors we need to consider before giving drug: comorbidities, different agent used in our available in our hand, dose range of the drugs. Now this is important. This slide is very much important for me also. Allopurinol. Why should we use allopurinol as a first line drug for gout patient? It is better to initiate low dose, though allocated dose or optimal dose or usual dose is 300 milligram per day. We are using 100 milligram daily. Those creatine clearance are normal, and we should escalate 100 milligram every 2 to 4 weeks to maintain uric acid level less than 6 milligram per DL. Why? To reach our target and to prevent or minimize adverse effect of allopurinol. Dose adjustment, I already mentioned, stage 3 CKD, we should give a common formula, CCR into 1.5. Though CCR is 30, we have to prescribe 45 milligram or not more than 50 milligram per day. Allopurinol adverse effect, everybody we are fair about these allopurinol side effects. Most common, not common, because side effects is not common. Side effect is serious side effect are DRESS syndrome, scars, severe cutaneous adverse reaction may occur with higher incidence, especially you know SLA-B 5801 LLE having patient and CKD patient. What is the DRESS syndrome? This is rare complication but a grave complication. We have to know at least name of this complications, DRESS syndrome. Drug reactions, eosinophilia, systemic symptoms. When this syndrome occurs as a complication of allopurinol, in that case it is called allopurinol hypersensitivity syndrome, and mortality rate is 25%. But interesting thing is it occurs only less than 0.1%. So for this side effect, you should not reduce the dose and you should not give homeopathic dose to avoid this rare and rarest side effect. The dramatic side effect has influenced, this dramatic side effect has influenced prescribing patterns toward the lower end and often inadequate dose. That's I am telling. Febuxostat, Febuxostat is another alternative drugs of urate lowering drugs. You know, everybody is, you know, available in our market. 40 milligram to 80 milligram is the usual dose. Some recommendation, especially European body, they advocate to use up to 120 milligram. In our Bangladesh, we are using, our teachers are sitting in front of us. They are also using up to 80 milligrams, so far I know. Very gradual increase of Febuxostat dose when starting therapy can help reduce the flare during this period. Adverse effect, you know, adverse effect is minimum and less than allopurinol. And important thing is that those patients show hypersensitivity with allopurinol, Febuxostat also may be the culprit of that particular patient. Uricosuric drug. You know, the patient developed gout. Majority of under-excretor, not over-producer. So we should use commonly uricosuric drug, not using. Why? This is a question for junior doctor. Why we are not using uricosuric drug, rather we are using xanthine oxidase inhibitor, that is under-producer. This is a question, big question. Patients with relative renal under-excretion of uric acid are potentially candidates for uric acid drugs. Next slide. Combination therapy. Combination therapy, we are not using this combination therapy because usually not required. You know, allopurinol dose is up to 900 milligram, but we think more than 300, we are fair about this, more than 300 or 400 dose, I think may occur any hypertension reaction or patient cannot tolerate, patient complain. In that case, we may add, when allopurinol dose need to prescribe more than 300 or 400, in that case, we may add allopurinol with hyperuricosuric drug. So many drugs are enlisted but not available in our country. Probenecid, benzbromaron, sulfenpyrazone, probably benzbromaron is not available. Probenecid and some markets, I think if you can purchase probenecid, at least you have to search 10 pharmacy to purchase it. So it is not available. I don't know, pharmaceutical company are not producing this drug. Uricase, just to know, this is for our curiosity, this is another important drug, uricase. It can rapidly reduce serum urate level because it can capability to destroy or convert urate to most soluble purine degradant product allantoin. So we can think about this. Pegluticase, this enzyme is not available in human body, but this is available in bird. That bird cannot suffer gout, never. But we can think about this. It can rapidly reduce the serum uric acid level. Dosage as administration, I don't like to discuss it in detail. You know, it 2 weeks, 8 milligram diluted in 250 ml normal saline and should be given in IV route. Role of surgery, actually no such important. Sometimes disfiguring tophaceous gout, when it compressed to other structure, in that case we may suggest a surgical decompression. Gout flare treatment, you know, I just like to skip this slide. We may use glucocorticoid. I like to show last slide, 2 to 3 slide for special situation group. Patient with an anticoagulation. Colchicine can be used safely and no effect on blood clotting. When colchicine is contraindicated, oral glucocorticoid can be used. If both colchicine and glucocorticoid is contraindicated, we can use intra-articular injection. And in NSAID, celecoxib may be used. So far, I know not available in our country. Atik sir is here. Sir's prescription I have found many times celecoxib previously, but I think no, nowadays not available in our country. I think celecoxib is a good drug. Older adult, this is a special group. Glucocorticoid, older adults generally tolerate brief course of oral glucocorticoid. NSAID contraindicated in majority of older patients because they have subsequent simultaneously heart failure, kidney dysfunction and GI upset. Colchicine myopathy and peripheral myopathy can be settled in older adults, although brief course we have to prescribe sometimes despite some sorts of complications. Pregnancy and lactation. Actually, female patient usually do not encounter gout-like picture or gout-like complications, but after menopause, it is same like male and female. Gout flare will be treated systemic glucocorticoid if patient has been suffering from these sorts of problem. Recurrent flare, high daily low dose glucocorticoid can be used. Who cannot take glucocorticoids, alternative option NSAIDs. And you know, during pregnancy up to second trimester, we can use NSAIDs. In breastfeeding patient who are either glucocorticoid or NSAID colchicine should be avoided during lactation. So this is my take-home message. Take-home message is actually what ACR says. ACR updated recommendation is my take-home message. Allopurinol is strongly recommended as first-line urate-lowering medications. Starting with low-dose allopurinol and febuxostat is strongly recommended over a higher dose. The use of pegluticase is strongly recommended against the first line of treatment. Using anti-inflammatory meds along urate-lowering meds is strongly recommended over not using anti-inflammatory medications. It is clear that urine-lowering therapy achieves its goal of lowering urate levels. Treat to target strategy by adjusting urate-lowering medications to reach a target is strongly recommended over using a fixed dose or no target. Thank you for patient hearing. This is our university, Bangabandhu Sheikh Mujib Medical University. Thank you all.
Thank you, Professor Dr. M.D. Abu Shahin sir, for his nice thoughts and insights. Actually, uric acid is antioxidant for our body, so too much lowering uric acid is hazardous for health. I am very sorry that I am ending my session very nearly. I am unable to have all question and answer session due to shortening of time. Now I am interested to invite Professor Brendranath Bhattacharjee sir to say something about this session.
Hi, very good afternoon, everybody. I have been asked to say something, but most of the gout has been said by Professor Roshanara and Professor Shain. So I have very little things to say. But what I saw in their presentations, one thing is very certain, that hyperuricemia is not gout, and even hyperuricemia, asymptomatic hyperuricemia, that it does not need any treatment. We as clinicians very often come across this question. Patients ask, sir, is it not better to check my urate level? And I think nowadays this uric acid craze is going on. And particularly this has been popularized by some of our physicians. Oh, I see your uric acid level is raised, so you should take febuxostat. But this is not the case. And there is definite indications when to start uric acid lowering therapy. Either xanthine oxidase inhibitors or uricosuric drugs. They have been elaborated by Professor Shahin. So almost everything has been done, has been said about gout. And the take-home message is that never give uric acid lowering drugs without definitive indications, like for example, tophaceous gout. And regarding this hyperuricemia, there is a controversy whether asymptomatic hyperuricemia with urate level above 12 milligram per deciliter persistently should be treated by uric acid lowering drugs. Some authorities recommend using uric acid lowering to continue in these cases. Some are against this, but there is some indications. In Japan, for example, what I learned from Atik Bhai, my apology to him is that whatever question, if I say anything wrong, all I learned from Atik Bhai, and any question, please ask Atik Bhai. Don't blame me. So that's all. And yes, there is Atik Bhai. So that's all what I have to say. And thank you very much. Thank this Rheumatology Association for giving me the opportunity to speak here. And thank you, everybody.
Thank you, sir, for nice comments. This time, I want to interested to hear from Professor Mujibur Rahman, Hauladar sir, Honorable Pro Vice Chancellor, BSMME.
Bismillahirrahmanirrahim. Learned audience, eminent speakers from home and abroad, ladies and gentlemen, I am privileged to say a few words presented as a chair of this session. It was a very interesting that has been presented by two speakers, the common problems of many human beings who are surviving in the world. They are suffering from this gout. So one important thing that is the common problems among the human being, but maybe from different issues that I have learned in this session. And there is a dilemma. You can see that the oral and general health. Our different study reports, and that has been shown, in many cases, the patients, those who are suffering from many systemic illness, like this type of autoimmune diseases or rheumatoid arthritis or many systemic illness, that can be the focus as a source of infection from the oral cavity. So this is the high time to think about the oral health status, because our oral cavity is a gateway of our general health. And those patients who are suffering from arthritis or some other problems, painful conditions in the human body, that may be primarily sourced from oral cavity. And that is one of the important condition is periodontitis, or sometimes maybe pain in the temporomandibular joint as due to temporitis or joint, many other joints of the body. So our message should be given to the audience: don't neglect the focus of infection from the oral cavity, please. Because sometimes oral manifestation is common for many systemic illness, but there are some systemic manifestation from oral diseases. So this is the time to work together between the surgeon and physicians. So surgeons should think about the physical conditions. At the same time, the physicians should have some oral approaches for the proper diagnosis and management of patients. With these few words, I would like to conclude. Thank you very much for the organizers for giving me the privilege in this session. Thank you all for patience.
Thank you, sir, for nice words. This time to hand over memento. First, I request Professor Birendranath Bhattacharya sir to hand over memento to Dr. Sabrina Yasmin as a nice talk. Now I am requesting to hand over memento to Abu Shahin sir by Professor Mujibur Rahman Hawladar sir, Honorable Vice Chancellor. And thank you from my side for patient hearing.
Dear audience, we are at the end of our today's conference, but we have another session left, that is raffle draw. Before going to raffle draw, for your kind information that there is your kind information that Bangladesh Rheumatology Society has developed a guideline for the treatment of rheumatoid arthritis, and it was published in a very prestigious online journal, that is Curious. It is available in online, also in Bangladesh Rheumatology Society website, and hard copy also website in our department. You may collect